Perfect. Salam, maybe you can just rename yourself so that you're not also me. Perfect. Good, good, good. Okay, great. I'm just gonna go. I was just trying to make sure that you were set, so I'll be right back, but I'll be back by 10:50.
Thank you.
Good morning. I think we've kicked everything off. We've got the webinar started, so just waiting for people to join us.
Thank you. Good morning.
Morning. Appreciate you making the time to instruct today.
Of course. Thanks.
All right, I'm back. This background's weird. Let's see.
Okay, I think we're ready to kick off when you all are ready to kick off.
Yeah, we're good.
And, feel free to flip your background around, Dr. Noureldine. I got every setting I think fixed except the default background, which should be our joint chapter logos. I apologize. I'll get that fixed for tomorrow. I can't
Okay,
edit it now that we're live.
got it. Great. Thanks. I appreciate it.
Yep.
Hey, Shannon.
Hey, how are you?
Good, good.
I was going to ask, do we stay on the whole time, or what do you want me to do?
No, Shannon. Well, I usually I signed you for tomorrow. I'm doing do today. I usually just do the intro for folks, and then will I have it muted in the background, and I just do some work, and then I
Okay,
do the goodbye and sort of welcome for the next day. So for tomorrow, you
okay,
can just hop back on at the just to send people off. Thank you for joining, etc. And then the
sounds
housekeeping stuff.
sounds perfect.
And then
Thank you.
Chris will make sure to record, which you are already. Great. Perfect. Oh, we've got some attendees in. Okay, great. All right. We'll go ahead and get started in about 2 minutes. Thanks for joining. Text your friends if they've forgotten about it. But
Yeah, Zoom sent out a reminder yesterday and a reminder about an hour ago to all the participants. So
Yeah, I got those reminders, so that's good. One thing for tomorrow, Chris, I'm going to send it to Jen and you. Dr. Gomal needs help driving the shared screen. He's really not that good at it. So um, I'll send it to you, and somebody will just have to step through it for him.
perfect. Jen is on to host tomorrow.
Oh,
So
great. All right. Good morning, everyone. It's 10:50, so I'm going to go ahead and get started. Welcome to the Combined Connecticut DC ABSITE Review course. We here in DC have been doing this course for over 20 years, and Connecticut has also had a course for a long period of time as well. And we decided to connect and sort of amplify our sources. And so we've got faculty from both the Connecticut region and the DMV region that will be hosting this ABSITE review this year. It is being recorded, and anybody who registered for the event will ultimately get the recording in about one week. Okay, so you'll still have it available for you to review before you go and take your ABSITE on the last weekend of January. Most of the lecturers really appreciate engagement and asking questions. You can drop questions in the Q&A, and those will be fielded um, by the person lecturing. And obviously, if there's any questions, like while somebody's talking, do feel free to just drop it in there. So we'll be monitoring those. Otherwise, enjoy the day. Hopefully, call life is not too bad, and you guys are getting your prep in for the ABSITE. So we'll go ahead and let Dr. Salam Noureldine pull up his slides. He is an endocrine surgeon at GW and spends a little bit of his time at Reston as well. We're happy to have him today to talk a little bit about the endocrine pathology that may be relevant to you on the ABSITE. Thanks again for joining us today, Dr. Noureldine.
Perfect. Thank you so much. You guys can hear me and you can see my screen, right?
Yes, I can hear you and I can see your
All
screen.
right. Perfect. We're good to go then. Today, what I wanted to kind of go over is just kind of the key things in terms of endocrine surgery that will come up on your app site. The key topics are hyperthyroidism and kind of the management of Graves' disease and toxic nodules. Thyroid nodules, you'll get a lot of questions about the workup and management. Thyroid cancer in terms of management and surveillance. We'll talk a little bit about the zebras, mainly the MEN syndromes, parathyroid disease, and then for adrenal pathology, it's mostly going to be the workup and then how you manage a FEO before you take it to the OR. And then we'll do, as long as we have enough time, which we should, we'll do a couple of rapid fire scenarios or highlights that I want you all to know before the exam as well. So in terms of Graves' disease, there are three treatments that are available once you diagnose somebody with hyperthyroidism and they have Graves' disease. The first one is antithyroid medication, the methimazole and the PTU. You should always get a pregnancy test before you start somebody on methimazole or make sure they're not pregnant because it does cross the placenta. Whereas PTU is safer in the first trimester. So if you have somebody who is pregnant and has hyperthyroidism, you start PTU, and after that first trimester, you can start methimazole. You have to keep in mind that sometimes on the exams, they might give you a scenario where somebody comes in on these medications with a rash, fever, sore throat. You always want to think of the side effect that can happen with these medications, agranulocytosis. You want to immediately stop the medication, check a white blood cell count, and you'll see that that's going to be suppressed. And, clinically, every once a year, we have to admit somebody into the hospital and start them on plasmapheresis because this can be missed. So that's something that come up on the board. If you have somebody rash, fever, sore throat, just think of that. You always want to check the liver function tests when these patients are on those medications, especially as you increase their dosing, because it does cause liver dysfunction and as it is being metabolized through the liver. It's not a great treatment option. It's kind of a temporary vehicle to definitive management. Because there's a high rate of persistent disease once you discontinue the medication, and again, you start building up those side effects. So patients and physicians don't like the patient to stay on it long term. And obviously, if you have somebody that is still tachycardic, you want to start them on a beta blocker. So that's the first treatment option. The second treatment option is radioactive iodine ablation. You give them I-131 to ablate their thyroid. Again, contraindications in here is pregnancy. And then, very importantly, on your ABSITE, they might give you somebody who has thyroid eye disease or kind of hint to having thyroid eye disease. So you want to keep that in your mind because it's a contraindication to give radioactive iodine for these patients with Graves' disease because it will worsen their thyroid eye disease and they can go blind. So whenever you have somebody who's pregnant, around kids, can't distance themselves from them, thyroid eye disease, radioactive iodine is not a treatment. It's a relative contraindication for large goiters and large nodules because you'll need more than one treatment session, two, three, for these large goiters or those patients that have multiple thyroid nodules, large nodules. And it's because there's a lot of data now showing that you're increasing the risk of secondary malignancies, such as leukemia, such as breast cancer. So the more you're giving them radioactive iodine, they're at a higher risk for those malignancies. So again, if you have a big thyroid or large nodules, radioactive iodine is not the best option here. And that leaves us with surgery. It's the best definitive option. And, in today's age, we are able to do these procedures safely with minimal morbidity, and patients can even go home the same day. The most important thing for you guys is you need to make sure that the patient is euthyroid before you take them to the operating room. Because if they're hyperthyroid and you take them to the operating room, you're squeezing on that thyroid as you're taking it out, you're going to cause a thyroid storm. So those patients, you want to make sure that they're on antithyroid medications, beta blockers, they become euthyroid or as much as possible closer to euthyroid. And plus minus, you can do Lugol solution where it firms the thyroid, decreases its blood supply, so it makes your surgery a little bit easier as well. In terms of toxic nodules, so you can have a toxic nodule or you have toxic nodules. So if you have somebody who comes in with hyperthyroidism, right, you check their thyroid TSH receptor antibodies to see if they have Graves' disease. If they don't, you can get an ultrasound. And if you see they have nodules, you want to know, could it be a toxic nodule that's causing this? And if they have multiple nodules, which one? Because if they have just a single nodule that is hot, as you can see here in figure C, then all you need to do is take out that lobe. If they have multiple nodules and only one lights up, again, you can just take out that lobe because you're only fixing the hyperthyroidism problem in those patients. If they have bilateral toxic nodules, then they need a total thyroidectomy. And then, as you can see in figure A, for patients who have Graves' disease, on a I-123 uptake scan, obviously they'll need a total thyroidectomy, but that's what it would look like. Now, this is different than I-131. Remember, I-123 is diagnostic. It's a thyroid uptake scan. I-131 has radiation, and those patients, you want to give it to those that have thyroid cancer. In terms of thyroid nodules, the vast majority of thyroid nodules are benign. So when you're reading the vignette, when you're taking care of a patient, when you're meeting them, you want to see, okay, which patient do I need to further investigate? Who is at a higher risk of malignancy? Who should I worry about? Because at the end of the day, 95% of the thyroid nodules are benign. We know men have a higher rate of thyroid cancer in their nodules, patients at extremes of age. So if you have a 15-year-old or if you have a 7-year-old, right, that's more concerning. If you have somebody who has radiation history, first degree relative of thyroid cancer, someone who's hypothyroid, they have a high TSH, those patients have a higher risk of thyroid cancer. If you have somebody who's coming to you with a rapidly enlarging thyroid nodule, that's very concerning. Or new hoarseness, those are, bad cancers until proven otherwise. So when you're reading the vignette, you have a 50-year-old woman who was undergoing a carotid duplex for screening, and she was found to have an incidental thyroid nodule. She's euthyroid, right? That's not somebody you would really want to worry about when you're reading that vignette. But if they tell you you have a 80-year-old man, he is hypothyroid for 10 years, and now he has a rapidly growing mass. Oh, and his voice is changing, right? That's when you change gears. It's like, okay, I'm really worried about this person. I need to do further investigation. Whereas somebody that doesn't have a lot of those high risk features that you can ask in clinic or see on the vignette, then you can, uh, take your time working up those patients if need be. The first thing you need to get anybody with a thyroid nodule is a TSH level, because if you have a suppressed TSH, then they're hyperthyroid, and could it be Graves' disease and they just incidentally have a thyroid nodule, or is it a toxic nodule? And that's where your I-123 scan will come in. And we know from a lot of data that hot nodules are rarely associated with malignancy. So if you have a hot nodule and it has reassuring ultrasound characteristics, and I'll go over that in a second, it makes sense just to go to the operating room and cure them of their hyperthyroid. For patients who have a higher serum TSH level, or they have a normal TSH, but it's closer to that upper limit of normal, 4.5, those I start worrying. Is like, okay, this could be a malignant nodule that I'm dealing with. And again, you're just kind of getting points, adding points to see when you're completing your evaluation, how aggressive do I need to be? Neck ultrasound is always the initial study that you would want, and actually sometimes it's just the only study that you'll need. It gives you a lot of information about the thyroid, the characteristics of the nodules, and you can easily evaluate lymphadenopathy to suggest any metastatic disease. And then we proceed with fine needle aspiration. We rarely ever do core needle biopsies for thyroid cancer, or for thyroid nodules, I should say. I would say 99.9% of the time, you just need a fine needle aspiration. Now, who needs a fine needle aspiration? When you look at the ATA guidelines, and those are the guidelines or the entity that provides us with guidance on how to work up patients with thyroid nodules, it says that FNA is the treatment of choice or procedure of choice when clinically indicated. So if you have ultrasound characteristics that are highly suspicious, once the nodule's over 1 centimeter, you want to go ahead and biopsy it because you're worried here about a malignancy. If it has intermediate suspicious characteristics, then you can wait until it grows to 1.5 centimeters, low suspicion up to 2 centimeters, very low suspicion. Those are like your spongiform or cystic nodules with a solid component, 2.5 centimeters. But again, you don't really need to biopsy anything that's less than 1 centimeter. And then obviously for pure cysts, those are almost always benign, and we don't usually biopsy them. Now, in terms of the ultrasound characteristics that you need to look for, or like on the vignette when they tell you, the ones that are highly suspicious, where they carry a 70 to 90% risk of malignancy just based on ultrasound characteristics, are the nodules that look like this. You have a nodule that is hypoechoic, meaning that it's darker than the consistency of the thyroid, as you can see here. If it has irregular borders, it's not smooth borders, that's concerning. Microcalcifications are worrisome. In breast cancer, macrocalcifications are worrisome, but in thyroid pathology, macrocalcifications are fine. We worry more about microcalcifications. And if you have an area where there's a rim of calcification, but you can see there's a break, that's obviously concerning. And at the end of the day, whenever you see an abnormal lymph node, you can see this is more of a round lymph node. It has a solid component within it. Then any thyroid nodule ipsilateral to it becomes concerning and highly suspicious for malignancy. So again, those are the nodules that once they get to 1 centimeter, you really want to work them up and find out what type of cancer it is, because most of the time it is a cancer. Then you have the intermediate suspicion nodules, and you can see this, the risk of malignancy drops significantly to 10 to 20%. Those are, again, your hypoechoic nodules, the nodules that are darker than the consistency of the thyroid, but you can see they have very small, smooth borders. and regular margins. And those you can wait. If they're growing over a centimeter and a half, yeah, you can then make sure that there's no malignancy hiding within them. And then your low suspicion nodules, those are the isoechoic, so the same color as the thyroid, or hyperechoic, those are the brighter than the color of the thyroid. Those nodules, as you can see, are associated with a 5 to 10% risk of malignancy, or those that are cystic that have a very small solid component. Those you want to wait until they prove that they're continuing to grow at about to 2 centimeters to further work them up. And then the spongiform nodules, the mostly cystic nodules, those you can see there's a less than 3% risk of malignancy. So you don't want to torture the patient. Just wait. If they grow over 2.5 centimeters, then you want to make sure that there's nothing hiding within it. And obviously for a pure thyroid cyst, as we said, there's a less than 1% risk of malignancy. So you really don't need to do anything about them. But this is what the American Thyroid Association guidelines say, and this is what we follow in practice, and this is what you should be answering on your boards or your exams is if you have a nodule that has irregular borders, it has microcalcifications, something that we don't show here, but increased internal vascularity. If you have an abnormal lymph node, ipsilateral on that side, those are the ones that you want to investigate when they're over a centimeter, and the rest you can wait once they grow larger in size. Once they're isoechoic, hyperechoic, spongiform, right, or more cystic portions within it, you can wait. And obviously, don't need to biopsy anything that's less than a centimeter. You would just kind of surveil those patients. Um, Once you do the FNA, right, you get that ultrasound findings, the ones that are suspicious or you have the criteria for a biopsy, you proceed with a biopsy. You're aspirating cells. It's a fine needle aspiration. It's not technically a biopsy. And the pathologist or the cytopathologist take a look at these cells under the microscope. Then they give you they follow the Bethesda criteria. It's called Bethesda because I hope there are no pathologists on this call, but I don't know, they're weird. They meet in Bethesda, Maryland to go over these and come up with these criteria. I don't know why they don't pick a nicer city to go to and to meet like Tampa or anywhere else. But anyway, you get these categories. If you get a non-diagnostic or unsatisfactory biopsy, that means you just did not get enough cells. And you need to repeat that FNA biopsy. If you did it the first time without ultrasound, you need to do it again with ultrasound. If they see some cells and they look benign, then, as long as the patient is not having any compressive symptoms of that nodules, because sometimes they can press on the windpipe, food pipe, cosmetically unappealing, bother the patient, then you don't really need to do anything about it. It makes sense to follow it clinically and make sure, if you have one data point, get another one in a year or two just to see is the trajectory that this nodule is going to continue to grow, where you can do something about it before it gets to 6 centimeters, or that this is a nodule that's benign because you biopsied and improved it, and it's not growing where the patient can be less concerned about it down the road. I'll skip the Bethesda 3 and Bethesda 4 categories, and I'll jump to the Bethesda 5 and 6. Bethesda 5 is suspicious for malignancy, and here they'll tell you it's suspicious for papillary, it is suspicious for medullary. And those patients, you can see up to 75% of the time, it is associated with cancer, and those patients go for a thyroidectomy. Obviously, if you get Bethesda 6, almost 100% of malignancy, and it'll tell you if this is papillary, if it's medullary, if it is anaplastic. Keep in mind here that FNA, you cannot diagnose follicular thyroid carcinoma or oncocytic thyroid carcinoma because in those cancers, you need to see capsular invasion. Remember, here you're just aspirating cells from inside the nodule. You're not taking out a chunk where you're maintaining the architecture of the nodule. So you cannot diagnose follicular thyroid carcinoma before surgery. Somebody might ask, well, can we do a core needle biopsy because that will retain the architecture because you're just coring the nodule and taking it. remember, you really need to investigate the entire nodule to see, millimeter, if there is any capsular invasion. So if you're that lucky to the point that you would have won the lottery, it's you cannot get a diagnosis preoperatively, essentially. For Bethesda 3, which is an ATP of undetermined significance, they see some cells. They don't have the full benign criteria. They have some nuclear atypia, cytoplasm atypia. So, it's not 100% benign, but it carries a 5 to 15% risk of malignancy. 10, 15 years ago, we would just repeat an FNA later on, or sometimes take those patients for diagnostic thyroidectomy or lobectomy. Same thing with the follicular neoplasm. Those are the ones that are mostly having follicular cells, could be a follicular carcinoma, but again, you see it's a 15 to 30% risk of malignancy. Molecular markers have been out for 10 years. I know, like, when I took my oral boards, they told you, like, yeah, molecular testing, you're unlikely going to get that on the oral boards. But now that molecular testings have been used and integrated into our practice for over 10 years, it is very reasonable for you to get asked about it, and even on the oral boards. And here for molecular testing, it's just like you're looking at the DNA and the RNA of the nodule. If you have a benign molecular profile, then that takes you back to square one. It's mostly consistent with a benign lesion. It has the same risk of malignancy, then you watch those patients. But if you get a suspicious molecular profile where you start identifying mutations that are associated with thyroid cancer, then it takes you up from that 5 to 15 or 15 to 30% risk of malignancy to 70, 80, and 90. And those patients, you have a better discussion with them that this is likely a cancer, this is a neoplasm, or one that is going to turn into a malignancy, that it needs to come out. So that's kind of the algorithm once you get the FNA biopsy results. Then, for thyroid cancers, we have the ones that are derived from follicular cells. That's the papillary thyroid cancers, and those spread through lymphatic spread. You have follicular thyroid carcinomas, mostly hematogenious, oncocytic thyroid cancers, and then when they dedifferentiate, they become anaplastic thyroid cancer. The parafollicular cells give you medullary thyroid cancer. You can get primary lymphoma in the thyroid. And if a vignette tells you somebody who has had Hashimoto's thyroiditis for 10 years and over 2 weeks they've had growth of their thyroid, and now they're having compressive symptoms, and it's over a 2 week period, that is primary thyroid lymphoma. The key here thing is those patients do not need surgery. They just need CHOP, chemoradiation, and in 3 months, their lymphoma of their thyroid goes away and their thyroid will shrink again. So if you get a vignette, somebody who's been on Hashimoto's thyroiditis, has been hypothyroid for 10 years, and all of a sudden, 2 weeks now, they have a diffuse enlarged goiter, that's lymphoma until proven otherwise. We'll still do an FNA biopsy. The FNA biopsy will tell you, like, there are lymphocytic cells, will give you that hint, and then as long as you keep it in the back of your head, that's somebody that you can do a core needle biopsy, so you can do your what's it called, to look and see what type of lymphoma it is, and help you with your diagnosis. And don't forget, like, any tumor in any organ, you can have primary malignancies, such as the ones that we just discussed, or you can have METs. And the most common METs to the thyroid is renal cell carcinoma, melanoma, lung cancer, breast cancer. So if somebody's had a melanoma in the past, and it was not an indolent one where there was metastases, lymphadenectomy required, they're in remission, or still undergoing treatment, and a nodule pops up and it's concerning, that you want to further investigate. So again, history is important here. In terms of treatment for papillary thyroid carcinoma, and I put here suspicious for follicular oncocytic, because again, you cannot diagnose those preoperatively or on cytology. So if you have somebody who has a malignant nodule, papillary, or one that is suspicious, and determine it has a suspicious molecular profile, you're thinking of a follicular-derived thyroid cancer. The options are you can do a lobectomy, just remove one lobe, and that's just makes sense, right? If you have a solitary tumor on one side, it's less than 4 centimeters. You don't have any nodules on the other side. You just need to take out that lobe. As long as there are no lymphadenopathy as well. You really need to investigate the lymph nodes in those patients and do lymph node mapping. For those that have multifocal or bilateral thyroid nodules, for those that have a thyroid nodule that's over 4 centimeters, for those that you see that they have a 2 centimeter nodule, but it's on the capsule of the thyroid and there's extrathyroidal extension, or those that have abnormal lymph nodes, you want to do a total thyroidectomy because those patients are going to need radioactive iodine. And when you're giving them a radioactive iodine, you're giving it as an adjuvant therapy to take care of any microscopic disease that's left. So if you just do a lobectomy and you give them radioactive iodine, that radioactive iodine is going to go to the contralateral lobe because the lobe is healthy and just wants more iodine. It's not going to go to the microscopic cells that are in the lymphatic channels or whatnot. So again, the reason why we're doing a total thyroidectomy on somebody who has these multifocal over 4 centimeter extrathyroidal extension lymphadenopathies, most of the time we need to give them adjuvant therapy. I'll skip the central neck dissection. Lateral neck dissection. For any thyroid cancer, you only do a lateral neck dissection when clinically you feel like, yep, there's an abnormal lymph node in the lateral neck. If you do an ultrasound, there's an abnormal lymph node, you biopsy it, it's abnormal. You only do a therapeutic lateral neck dissection always for all types of thyroid cancers. Now, for central neck dissection, those are the lymph nodes that surrounding your thyroid and the ones that are between your carotid sheaths. You almost always will only do a therapeutic neck dissection, meaning that on ultrasound, when you're evaluating those patients with thyroid nodules that you're suspicious of a thyroid cancer and you see an abnormal lymph node in the central compartment, you biopsy it, there's metastatic disease. Or for those that when you're doing surgery, you see an abnormal lymph node, you sent it to for frozen section analysis, and they tell you that there's cancer cells in there. Those get a therapeutic neck dissection. You need to clear those prelaryngeal, pretracheal, and at least an ipsilateral paratracheal lymph node basin, and that encompasses a central neck dissection. Now, for prophylactic wise or prophylactic central neck dissection, you only want to do it for tumors or consider doing it for tumors that have gross extrathyroidal extension. You know, the T4 tumors, the tumors that you show that they're aggressive in that region because most likely you'll have significant lymph node burden, but you're not picking up with your ultrasound. Adjuvant therapy is radioactive iodine, and as I said, you must have a complete thyroidectomy before you proceed with it. The indications, you know, if you have a tumor that's over 4 centimeters, if you have aggressive histology, you know, the tall cell variants of papillary, the sclerosing variants of papillary, for if you have vascular invasion and more than 4 foci, that's usually for follicular thyroid carcinomas. If you didn't do an R0 resection, if you have positive lymph nodes, distant mets, or gross extrathyroidal extension of the tumor, those patients you want to give them adjuvant radioactive iodine ablation. And then for surveillance, again, we go back to the ultrasound. It's a good study. A lot of these cancers are papillary. They're going to metastasize to the lymph nodes. So you can ultrasound the central compartment lymph nodes. You can ultrasound the lateral compartment lymph nodes. If you did just a lobectomy, you can surveil that contralateral lobe and make sure that there are no nodules that are forming on that side. And then you can check also your thyroglobulin and thyroglobulin antibodies. Thyroglobulin is just a protein that thyroid cells make and thyroid cancer cells make. So once you take out the entire thyroid, now it becomes a tumor marker where hopefully after your thyroidectomy, that level is undetectable. And then over the years, you can check it. And if there's any increase in that level, that gives you suspicion that there's biochemical evidence of recurrence and you start being more diligent in looking where that disease is coming back. For patients who have differentiated thyroid cancer, follicular, papillary, oncocytic, we surveil them every 6 months for the first year and then annually, ultrasound, thyroglobulin. In terms of medullary thyroid cancer, most of the time it's sporadic. However, whenever you get a medullary thyroid cancer on your ABSITE, on the boards, or what have you always got to hit the brakes, and you always have to ask yourself, could this be MEN2, MEN2B, 2A or 2B, or a familial component of medullary? Because again, once you get somebody who has MEN2A, MEN2B, the main thing here is the pheochromocytoma. So on the oral boards, if you give you somebody with medullary thyroid cancer or an indeterminate thyroid nodule, you get molecular testing, suggests medullary thyroid cancer. You want to pause the brakes and see, like, do they have any signs or symptoms of a pheo? Do they have any family history? Oh yeah, my, mom died from a weird cancer in her adrenal and she had blood pressure issues or whatnot. Take a good history. Make sure you're not missing a pheochromocytoma because on the boards, the patient will die on the OR table if you're just taking them for the thyroidectomy. And in real life, you don't want to do that either. So whenever you get medullary thyroid cancer, always pump the brakes and make sure that you don't have MEN2A and MEN2B. And I've listed them here for you. Sporadic tumors are usually unilateral, but almost always involve the lymph nodes. And that's why the treatment is going to be different than the differentiated thyroid cancers, the papillaries, the folliculars, and the oncocytic ones. And familiar tumors are generally multifocal, and MEN2B is the most aggressive form. For MEN2B, mucosal neuromas, this is what they would look like for you. Um, on the app side and even on the written boards, they'll ask you for somebody who has the RET mutation, what is the recommendation for their offspring? And you can see here, because MEN2B is very aggressive, in their first year, you would want to do a thyroidectomy for them. And on the boards, on the app site, they'll ask you, offspring of an MEN2B. Are you going to do a total thyroidectomy? Are you going to do a lobectomy? Are you going to do total thyroidectomy, central neck dissection, total thyroidectomy, central neck dissection, lateral neck dissection? Remember, here we're being proactive. We're doing this prophylactically. So we don't need to address the lymph nodes. We're just taking out the thyroid that has the C cells that are going to form into medullary in those patients. For MEN2A, you want to wait for the child to wait for to become 5 or 6 years, and similarly with familiar medullary thyroid cancer. All right, so here, offspring, remember, it's just a thyroidectomy that we're removing. We're not addressing the lymph nodes. We're being proactive. In terms of the treatment, surgery is the only curative method. You never want to answer radioactive iodine ablation for medullary thyroid cancer. It's never the right answer, right? It's not follicular cells that have the problem, it's the C cells. And the treatment here is always a total thyroidectomy, a prophylactic central neck dissection. And again, because most of the time the lymph nodes around that thyroid are almost always involved. And then you only do a therapeutic lateral neck dissection. Only if your ultrasound, your CT suggests that there's disease in that lateral neck compartment that you take out those lymph nodes. You never do a prophylactic lateral neck dissection for any thyroid cancer. Um, Things that might pop up, we really rely on calcitonin preoperatively to tell us how extensive the disease is and how aggressive we need to be. There's good data that shows that if your calcitonin level preoperatively is less than 40, your disease is just inside the thyroid. It has not yet spread to the lymph nodes. If your calcitonin is over 40, then it's likely spread to the lymph nodes. Now here, I would still answer on the boards or your app site. I would do a total thyroidectomy prophylactic central neck dissection. But in real life, we have these discussions with patients that, look, you're likely going to have disease just in the thyroid because your calcitonin is 20. We might not need to address the lymph nodes. And you just have that, risk benefit discussion with the patient. On the boards, it's just total thyroidectomy, prophylactic central neck dissection. More importantly, when you have somebody who has a calcitonin over 400, or in some studies show over 200, you really want to do your staging and rule out any metastatic disease outside the neck, because once the calcitonin is over 400, it's likely outside the neck already, into the lungs, into the liver, and you want to find it to guide your treatment. Calcitonin and CAA are the tumor markers after your surgery for medullary thyroid cancer. You want those to hopefully normalize or be undetectable. That's when you can get a complete biochemical response. Sometimes they can be remain elevated, and those patients you want to continue to surveil every 3 months, 6 months, and then every year to see if that calcium is doubling, or you want to see where the disease is coming back. If the disease comes back, it's always surgery. If the disease comes back, it's always surgery. You'll only start relying on adjuvant radiation therapy when you're like, if I go back, I'm going to have to take out the trachea, and that's going to be very morbid for the patient than you do radiation. But as long as you're able to go back and remove more disease with minimal morbidity, surgery is always the option. Remember, your MEN syndromes, whenever you're taking care of a patient with medullary, whenever you hear medullary, whenever you hear a scenario, you just pause. It's like, am I missing a pheochromocytoma? That's the key thing here. For anaplastic thyroid cancer, we all know that it's very bad. Usually, the vignette will be an older man, palpable mass, rapidly growing, and they're hoarse. And when you feel them, it's like hard as a rock. Those patients, when they see you in clinic, they already have pulmonary mets, they already have bone mets, they already have liver mets. Sometimes they have brain mets as well. It's a very aggressive disease, and surgery, our role is usually palliative. You sometimes just need to trach them, but once you have somebody, you want to get that diagnosis as soon as possible so you can get them to chemotherapy, you can get them to radiation therapy, and nowadays you want to get that BRAF mutation. That's something that's now considered new, so it just can start coming up on your boards or your ABSITE that anybody that you have anaplastic thyroid cancer, you get immediately a BRAF mutation because you want to see if there's immune therapy options. And studies have shown that, again, these patients are doing a little bit better. Still, the prognosis is grim, but they're doing better. And again, there's no role for radioactive iodine ablation in those patients. Switching gears, parathyroid disease. So for parathyroid disease, mainly you have your primary hyperparathyroidism, secondary hyperparathyroidism, or tertiary hyperparathyroidism. And although, we only get to see parathyroid cancer once every, 5 to 10 years, the exams, the boards always love to ask about it. For primary hyperparathyroidism, the majority of cases are sporadic, right? But again, whenever you have a patient with primary hyperparathyroidism, you want to pump the brakes and make sure that they don't have MEN syndrome. And here you can have MEN1, the 3 Ps, pituitary, parathyroid, pancreas, or MEN2A, where you have parathyroid problem, medullary problem, and a pheo. And again, you're pumping the brakes to make sure that they don't have a pheo. But again, most of the cases, almost always, is sporadic. And most of those patients have a single adenoma that is the problem. Some patients have more than one adenoma, or some patients have multi-gland hyperplasia where all 4 of the glands are abnormal. In terms of the diagnosis of primary hyperparathyroidism, we look at the serum calcium and we'll look at the PTH, and that's kind of a good place to start at. If the PTH is elevated, if the calcium is elevated, it's always primary hyperparathyroidism. You don't really need any additional tests. If the PTH is elevated or mildly elevated and within the normal range, and there's hypercalcemia, it is likely primary hyperparathyroidism, but those are the patients that you want to further investigate. You want to get a phosphorus level, and that's going to be low. You want to get a 24-hour urinary calcium level, because in those patients where the PTH goes up and the serum calcium goes up, your kidneys are going to try to get rid of that calcium by peeing it off. So if you get a 24-hour urinary calcium, you're going to see it's going to be 200, 300, 400. Whereas an important differential diagnosis is FHH, and I'll go over that in a second. You'll see that the 24 urinary calcium is going to be on the lower end because they have a mutation in the calcium sensing receptor, and I'll go over that in a second. So you need to be mindful of that, especially on the boards or ABSITE. That is the one that they're going to have you contemplate if is it primary or is it FHH and why, or how can you get to that point. FHH is autosomal dominant, so it's very important to get a family history. Did your mom and dad have parathyroid problems, kidney stones? And it's characterized by a loss in the function of the calcium sensing receptor. That calcium sensing receptor in the parathyroid usually causes a feedback inhibition of PTH release, and in the kidney senses high calcium and therefore decreases tubular reabsorption of calcium. However, in patients who have FHH, where they have a loss in the function of the calcium sensing receptor, there's no more inhibition on PTH on the parathyroid part. So they have higher PTH levels, and that lead to higher calcium levels. So it mimics primary hyperparathyroidism. But those higher PTH levels are usually mild. Like if your upper limit of normal is 80, it's going to be 80, 85, 90. It's not going to be like 200 usually. And then the calcium sensing receptor in the kidney, and that's where you can really differentiate in terms of the diagnosis, that there's no more inhibition on the renal calcium reabsorption. So more of the calcium will get reabsorbed and they will have a low urinary calcium. So if you have somebody that has a PTH of 90, mildly elevated, a calcium of 11, and you check your 24-hour urinary calcium and their 24-hour urinary calcium is 90, that patient has FHH. The way to diagnose it, send them for genetic testing, and you'll identify that mutation. However, if you have that same patient, PTH is 90, calcium is 11, and then you get a 24-hour urinary calcium and it's 300, primary hyperparathyroidism. And this table kind of summarizes the different lab values in terms of the most common pathology that you will see on your ABSITE or your boards, where in classic hyperparathyroidism, your PTH is high, your serum calcium is high, and you can see you have a normal to high urinary calcium. In terms of FHH, you have a normal to high PTH, high calcium. Sometimes the ionized is not really elevated, but your urinary calcium is low. For secondary causes such as vitamin D deficiency, you'll see that your PTH is high, calcium not really, but your vitamin D will be very low. And once you can fix this problem, the patients, this is kind of a physiologic issue that once you fix it, it will go away. For the treatment of primary hyperparathyroidism, surgery, right? And remember here, it's very important that we did not discuss preoperative imaging as a criteria for the diagnosis, right? It's all biochemical. It's all on labs. So if on the boards, on the exam, they tell you, you have somebody has a high PTH, high calcium, and their imaging studies, the ultrasound CT, 4D CT, what have you, shows nothing. What do? Monitor the patient, do nothing, take them to surgery, you take them to surgery. Because the preoperative imaging is just a roadmap for the surgeon. It helps my life, makes my life easier when I have a patient that has primary hyperparathyroidism. I get an ultrasound, I find a lesion, I get a CT scan, a system EB scan, it co-localizes the lesion. Then I now go in knowing that this is likely going to be single gland disease. I'm just going to deal with one parathyroid. It's not going to be a hyperplasia case. Again, so preoperative imaging is just a roadmap for surgeons. It is not a criteria for surgery. So if you have somebody who has the diagnosis biochemically, take them to the operating room. We have intraoperative adjuncts. That most common one is intraoperative PTH and has come on the boards and ABSITE in the past. You need to know that there are two criteria, the Miami criteria, which you want a 50% drop in that PTH level before excising the lesion to after 10 minutes after of a 50% drop. A lot of people use the dual criteria, which is a 50% drop and into the normal range. Meaning, if you get your pre-excision PTH and it's 400, 10 minutes afterwards, your PTH is 200, That's the Miami criteria. They tell you like you're likely gonna be okay. But studies have shown that you may have a higher rate of failure, that there could have been another adenoma and you're missing it. So you really want to follow the dual criteria of a PTH of 400, you want that level to be 60, right? Less than 80. So more than 50% drop into the normal range. If that doesn't happen, you need to explore, even though that your ultrasound or your CT showed that you have one lesion, because you're going to likely have another tumor, adenoma, or hyperplasia. In terms of the secondary hyperparathyroidisms, you have chronic renal disease is usually what causes it, sometimes severe vitamin D deficiency. Here you have kidneys that cannot absorb calcium, so you're losing a lot of calcium and it causes hyperplasia of the parathyroids. So your PTH is high and that leads to high phosphorus, but your kidneys cannot hold on to calcium, so your calcium is low. And again, this is a secondary cause. You're losing calcium in your urine. Parathyroids are reacting. So all four of the parathyroids are abnormal here. And in those patients, you want to increase their vitamin D, give them phosphorus or calcium binding resins. Cinacalcet is used in a lot of those patients. You really need to get them to a kidney transplant because 30% of the time they'll get resolution. But for those that have a high phosphorus and then eventually will have a higher serum calcium, not elevated, but normal high, those patients that have a higher phosphorus and then their serum calcium starts becoming 9, there's a calcium phosphide product where you can measure, and if that level goes up, they can have start developing calcification of their soft tissue, their vessels, and those patients we're worried about because they'll have more cardiovascular disease. If you transplant their kidney, give them a kidney transplant, they're calcify the vessels of the graft as well. So those patients you want to treat. And again, because it's a 4-gland disease, you always want to take care of the 4 glands. Either you do a total parathyroidectomy with autotransplantation or a subtotal parathyroidectomy, meaning you remove 3.5. I doubt that they'll put both on the exam because they're two schools of thought and they're both the same answer. A lot of studies have shown that if you do a subtotal parathyroidectomy, 3.5, there's less morbidity in those patients. Because think of it, when you're removing all 4 and auto-transplanting some in the muscle, it's going to take 3 to 6 months for that graft to start functioning and producing PTH. So that patient is going to be significantly hypocalcemic for 3 to 6 months. And those patients are not usually the ones that are very compliant with medication, or there are a lot of other comorbidities that are going on. Mortality is high. So if they happen to give you both answers on the boards, subtotal parathyroidectomy makes sense. The only time I would pick total parathyroidectomy is secondary hyperparathyroidism patient if it's somebody that you know will never get a kidney transplant. They're going to be on dialysis for the rest of their life. You could do a total parathyroidectomy. They'll get their calcium whenever they're getting dialyzed every 3 days, and they will not get hypocalcemic. For tertiary, it's the same problem, right? Kidneys didn't work, parathyroid hypertrophy, and then you give them a kidney. So now the kidney responds to that signal from the PTH. So the PTH is high because all 4 glands are hyperplastic, and now the calcium starts going up and the phosphorus is up. So in those patients, we worry about their graft from calcifying. So those you want to do a subtotal parathyroidectomy or total parathyroidectomy with autotransplantation. You don't want, like, they might tell you on the exams, like, oh, tertiary hyperparathyroidism, and you get an ultrasound and there's a 4-centimeter adenoma. You never just want to go in and remove that adenoma because all 4 glands are abnormal. For that patient that you just go in and remove that single gland, the next day their lab biochemical profile is going to be completely same because they have 3 other glands that are abnormal that are contributing to that PTH being high. Parathyroid cancer, usually a man, older, severe hypercalcemia, very high PTH, palpable mass, unilateral vocal fold paresis. That's parathyroid cancer until proven otherwise. And for those patients, the main thing here is you really want to do a in-block resection. You take out their lobe, you take out their parathyroids, and you take out their lymph nodes, and sometimes you have to sacrifice the recurrent laryngeal nerve as well. For adrenal, let me see how I'm good on time. All right, I'll go a little bit faster. For adrenal, The tumors, the main thing for you is to differentiate, is this a tumor that is a cancer, primary cancer of the adrenal or met to the adrenal, or is this a functional tumor where the adrenal, it's a hormone gland that produces hormones. Are we producing too much hormones? So you always want to have both of those questions whenever you have an adrenal tumor. You can't be like, oh, this is benign, I'll forget about it, it's not a problem. No, it could be benign and functional. It could be cancer functional, but you always want to remember the functional part as well. For the functional side, hypercortisolism, you have Cushing or just mild autonomous cortisol secretion. You would test all patients for this that have an adrenal mass. All patients over a centimeter adrenal mass, you test for this. And you do a dexamethasone suppression test. You don't check a random cortisol. They could be crossing the street before they go to the lab and somebody was about to hit them in the car and their cortisol level is high. And then you're like, oh, your cortisol level is high. What do I do with that? You give them dexamethasone. So the next day when they go to the lab, their cortisol level shouldn't be high because there were steroids already in them. And then for confirmation, you can do 24-hour urinary cortisol level or salivary cortisol levels at night to confirm the diagnosis. Hyperaldosteronism, right? Anybody who has hypertension with or without hypokalemia, you need to check an aldosterone renin and you want to see that aldosterone being high. You do not need any confirmation testing. And then the uh, PHEOs, right? So any tumor that has a Hounsfield unit over 10, you need to check for a PHEO. And you want to see those plasma metanephrines to be over twofold. And plasma metanephrines, urine metanephrines, whatever is convenient for you, whatever your institution practices, they're both the same. We usually use plasma because it's faster. Okay. Now, in terms of whenever you get an adrenal incidentalloma, and let's focus on the left side first, to rule out function, right? If you have somebody with an adrenal incidentalloma on a CT for their, abdominal pain, the first thing you look at is size. If it's less than a centimeter, then you do not need to do any workup from a functional standpoint unless the patient tells you, oh, doc, I have a history of hypertension. You need to get an aldosterone level. You need to get a renin level to make sure that they don't have hyperaldosteronism. Okay? Over a centimeter, everybody gets a dexamethasone suppression test. And you want to make sure that they don't have hypercortisolism. After you do that, you want to look at the Hounsfield units of the tumor. If the Hounsfield units of the tumor are less than 10, then the additional thing that you need to do is just make sure they don't have hypertension to rule out an aldo. If their Hounsfield units are over 10, then you need to rule out a PHEO. Everybody gets metanephrines in those patients, whether symptomatic or not. Okay, so from a functional standpoint, incidental 9 millimeter right adrenal, whatever, lesion, tumor, adenoma, whatever they call it, it's 9 millimeters, less than a centimeter, no history of hypertension, no workup needed. 3 centimeter lesion picked up when somebody was getting a non-contrast CT for their kidney stone. Okay, it's 3 centimeters, so dexamethasone suppression test. It's a non-contrast study. You look at the Hounsfield units, less than 10. They don't, if they have a history of hypertension, you do aldorenin. If not, then you're done. If it's over 10, you want to rule out a pheochromocytoma. From a cancer standpoint, size, again, is the same thing that you follow. If it's less than 1 centimeter, you want to make sure they don't have a history of a malignancy. Oh, I had a melanoma, colon cancer, what have you, right? They can metastasize to the adrenal. If they don't have any history of malignancy, it's less than a centimeter, then you really don't need to follow up those patients. If it's over a centimeter, again, you look at the Hounsfield units because you want to see if this is a lipid-rich lesion. Lipid-rich is good. And those patients, you know that they're benign. So no follow-up is needed, especially when it's less than 4 centimeters. If the Hounsfield units are over 10, then this is a lipid-poor lesion. There can still be a lipid-poor benign adenoma, but you need to figure that out. That's when you would get an adrenal protocol CT with washout characteristics. If this is a lipid poor lesion that does not wash out, this is a cancer until proven otherwise, that patient needs to go to the OR, needs to come out. If it's a lipid poor lesion and it has good washout characteristics, then this is a lipid poor adenoma. It's benign, and those patients, if it's less than 4 centimeters, you can follow them up every year. If it's over 4 centimeters, you can talk to them like, yes, this is lipid poor, likely an adenoma, but it's over 4 centimeters, high risk of malignancy. You can talk with them about taking it out. But again, anytime you get an incidentaloma, you want to make sure it's not functional and you want to make sure it's not a cancer. It's not either or, right? Oh, it's less than 1 centimeter. Hounsfield units are less than 10. A lot of people just call it benign and don't worry about it. And then you find out later that they have hypercortisolism or whatnot. Pheochromocytoma, you want a phenoxybenzamine, block those patients, alpha blockade, doxazosin, and then followed by a beta blocker. And then during surgery, you want to avoid excessive manipulation of the tumor, take the vein first, debulk, and remember your MEN syndrome. So if you have a medullary and whatever, it's metastasized to everywhere, take out your pheo first and then deal with the medullary. All right. Let's finish up with some rapid fire. So on the boards, they can give you a picture of this. This is somebody who just had thyroid surgery, and this is what their laryngoscopy shows. You can see here that they have bowing of their vocal cords, and you can see that there's a little bit of inferior displacement or rotation of the larynx. That is an injury to the external branch of the superior laryngeal nerve, the muscle, the nerve that innervates the cricothyroid muscle. You can see here that they have bowing. So you know that there was an injury to that external branch of the superior laryngeal nerve when taking down the upper pole. If you have an injury to the recurrent laryngeal nerve, then you can see that cord is not going to work on that ipsilateral side where you would expect it to join and connect immediately. Parathyroid embryology is important because they might ask you the superior parathyroids, they come from the fourth pharyngeal pouch. So you can see there's less transfer, less course, shorter course. So they're less variable in their location. The inferior ones come from the third, and you can see they go all the way down to the thymus, then the thyroid. So that's why the inferior ones are usually ectopic. When you get a patient who's considering or like in the workup of undergoing thyroid surgery and they tell you like they have a aberrant subclavian artery, the first thing you should think of is that patient is going to have a non-recurrent laryngeal nerve, right? Because you can see here the recurrent laryngeal nerve goes underneath the subclavian and goes up, but here, because you have an aberrant subclavian, you're going to have a non-recurrent laryngeal nerve. And that has very important implications during surgery because when you're looking from the nerve or when you're mobilizing the thyroid, if you're just going cut, 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 and then looking for the nerve, you've already cut the nerve. Okay? Cytology, they've been getting questions on the oral, the written boards, the ABSITE, PTC, Samoma bodies, they'll show you nuclear pseudo-inclusions, papillary formations, that's papillary. Um, Medullary, they'll show you spindle cells, they'll show you amyloid deposits, lack of colloid, this is medullary. This is pathology. Remember, follicular you cannot diagnose on cytology, and the reason is you want to see that there's capsular invasion. This is a capsule of the nodule of the cancer, and you can see this is a follicular thyroid cancer invading through the capsule. Differentiated thyroid cancer, or thyroid cancer, I should say, is the only cancer that age goes into the staging system. So if they tell you somebody has a 6 centimeter thyroid cancer, lymph nodes in the central compartment, lymph nodes in the lateral neck compartment, what stage are they? You should ask, the first question is, how old are they? Oh, they're 30. They're stage 1 unless they have metastatic disease, right? Over 55, then you can have 4 stages of disease. Thyroglossal duct cyst, remember you need to take out the hyoid bone during your cystrectomy procedure, and then you take that whole tract from the thyroid pyramidal lobe all the way up to the foramen cecum. The last thing I'll leave you with, just kind of if anybody has visited the statue of David, I don't know if you noticed that David has a thyroid nodule, right? So David would need a TSH level, and then David would likely need a biopsy, and then you need to counsel him that he's a man with a big nodule. It's likely a malignancy that you need to work up. So thank you for your attention. Happy to take questions. Hope I'm not over time.
No, you did great. You're 2 minutes shy, actually. Anyone have questions on the endocrine section? Feel free to drop them, or feel free to... There's a chat and there's a Q&A section. Good. Well, thank you, Dr. Noureldine, for that wonderful lecture. I learned a few things. I didn't know that David had a thyroid nodule. I also liked your images. Images are sort of high-yield things on the ABSITE, so like things that are pathognomonic with pictures are sometimes some really good quick shots for you to sort of hammer in your brain, because those are some high-yield and sort of easy gimmies for the ABSITE test. Thanks again for being with us today. We really appreciate it. I have two Dr. Plerhoples. I hope I'm saying that right. I'm probably saying it incorrectly. Who's going to go through the Alimentary tract with us today. Templar. Oh, there you are.
Hey, sorry, trying to get it all together here.
And how do I say your last name?
Plerhoples.
Plerhoples. Okay.
Yeah.
I was not close. Okay. Thanks, Dr. Plerhoples, for joining us today.
Sure.
You can go ahead and pull up your slide.
Yeah, let me get through that. Hang on a sec. Sorry, I'm getting there. All right. Wow, my computer is super slow this morning here. All right, let me see if I can share my screen.
It's okay, no worries.
All right, can you see it?
It is loading, but I know it's trying. Perfect.
Can you see it? Okay.
Great. All right, take it away.
Cool. All right. Kind of just wondering who's on the call here. The residents. How many residents do we have?
We've got about 11 residents who are presently on. We have a total of 40 registered.
Okay, kind of on and off. Okay. Well, this is the first time I'm giving a talk like this, and for the ACS, and I have to admit, I've been a little bit out from the world of ABSITE. I don't think I've taken the ABSITE in well over a dozen years, and when I took it, it was still the junior and senior exam, and I know it's not anymore. So happy if anybody has any questions, please stop. This is gonna be like super boring if we just do it this way for an hour. I don't know if you can wave your hand or whatever it is, or just pop on, but I'm perfectly happy to stop and answer questions you guys might find to be more relevant. I took this, let me get to the I took this from the last time it was given, so it's from Dr. Sarah Berkey, so I don't know if she's on, but appreciate that. So we'll just run through here some of this stuff really quickly. Anatomy is, of course, important. I'm a colorectal surgeon. I should say I'm from the Inova system. I work for Fairfax Colorectal Surgery. I've been there for a long time. I'm mostly going to be focusing on the colon, because that's what I know, and some of the disease of the small bowel. So the anatomy, obviously important, especially for our vascular dissections for oncologic surgery. The main arteries, to the colon. Gosh, I hate doing this without having you guys answer the questions, but I'm going to do it, I guess, anyway. So the main artery from kind of proximal to distal is the SMA, or the ileocolic, as it turns into the ileocolic. Here, there's really no such thing as a right colic. There are some aberrations of that, but we don't consider that oncologic. The next major oncologic branch is the middle colic, that branches to the right and the left, and each one of those is considered oncologic. And then really nothing down all the way until the IMA comes off. All sorts of branches there. There's the left colic, the sigmoid, and then of course the IMA as it continues down to the rectum. When it gets closer to the rectum, we give it a different name. We call it the superior rectal artery, and that's just sort of the same continuation of that, and that's important for when we talk about what operations we do. I guess the right side, of course, is the embryology of it, and how it twists and how that can result in alterations to that. The venous drainage does not follow it really, not considered quite as important, but is still fairly important. Most of it goes to the ileocolic vein on the right side, and most of it goes to the IMV on the right side. Sometimes we'll take the IMV high, and some people advocate that for cancer operations, but for the most part it's not. And then the further down you go, closer to the anus and the distal rectum, it drains into the inferior rectal, which goes more towards the iliacs and the groin. So that's important for cancers there, and ultimately going through the portal veins. It's the thought to how this metastasizes to the liver. Colon cancer metastasizes to the liver. Lymphatic drainage is similar. We don't need to spend a lot of time on that. The things, this seems to come up, especially on the kind of the junior type questions there. What differentiates colon from small bowel and rectum? Of course, the colon have haustra, so that's the long, the folds as the transverse folds as it goes, and the tenei coli, which is the long strip of muscle that goes along the colon. And then it is, of course, this is one of my favorite OR questions, is the colon has anti-mesenteric fat all over it, and there's only one place in the small bowel that has anti-mesenteric fat, and that's called the ligament of Treves, right at the terminal ileum. So that helps you identify that. Resection margins. I don't know where these questions come from. Resection margins for diverticulitis. Okay, this is what they're saying, I guess. So I don't know why we're jumping to this, but the tinea are useful here to help you see where the colon turns into the rectum. It's very important to take all of the sigmoid colon when you do a diverticular resection, and that's one of the ways that we help decide that. Why? Well, if it's going to recur, it's going to recur distally typically, and that's where the rectum. That's where we differentiate the rectum. The anus has its own sort of anatomy. So you can spend obviously a career trying to understand this better and better. Essentially, distally there is the squamous cell along the skin, and then across the anal verge. The anal verge is defined by what you can see if you manually spread the buttocks but not go inside. So that then turns into the anal canal or the anoderm, and that is still typically squamous cell. And then, of course, at the dentate line is when it transitions over to columnar. So cancers that are right there can be either squamous or adenocarcinoma. And that's where a lot of our problems in the anal canal come from, the dentate line. Of course, that's where fistulas, abscesses, etc. come from. We can talk about that. The internal sphincter, this is one of the fun questions they seem to ask all the time. The internal sphincter is the continuation of the circular muscle of the rectum, and as such is an involuntary muscle. It's tightly closed all the time except for when it's time to go to the bathroom kind of thing. And then the external sphincter, they're not going to ask you specific levator ani muscles, etc., but those are the ones that are more voluntary and can be involved in pelvic floor problems. Okay, malignancy, 99% of the time, colorectal cancer is adenocarcinoma. Anal cancer is, of course, 99% of the time is squamous cell. Appendiceal can have some different things, and then lymphoma, some of the weird ones. Lymphoma GIST, they always seem to like to ask those, so we'll go through those. Very quickly, colon cancer is common, and it kills a lot of people, and it's rising, especially young people, which we don't know why. Risk factors, age, of course, is a big one, much more common. So even though it has rising frequency in young people, it is still extremely uncommon. It's just much more common in the elderly. Males have a little bit, tiny bit higher, but not really much. Ethnicity, of course, is thought to be related to socioeconomic status more than anything. Diet, I don't know that there's a real strong association for that. I know, it's cited, but I don't think that would be a great answer on the test. Of course, personal history is by far the most important thing. Oh wow, I just looked at my screen. I look like a maniac with this background. Let me get rid of that background. There we go. Now I look normal. Personal history is by far the most important thing. So this is important when you're sitting out at the dinner table, at Thanksgiving or something. So if somebody's had a colonoscopy and they don't have any polyps, that's actually really important information, much more important than family history or anything like that. Family history actually plays a very rare part in this, even though we spend a lot of time talking about it with patients. Why? Well, 75-80% of colon cancers are sporadic, meaning they come from nowhere. It's only about 10 or 15% we think are familiar at all, and a very rare amount, about 5 or 10%, are related to some known genetic thing, typically Lynch or FAP, which we'll spend a couple minutes on. Here's sort of the talk about the young rising there, and that's just really an active area of research. This is the polyp kind of pathway. You guys probably remember this better than me, but the kind of the clinical side of things is that it does help us a lot more now than it used to. Why? Well, if it's from specifically this MSI or microsatellite instability pathway, there are different treatments that we can do now. So a huge majority come from just typical chromosomal instability. This is a good, kind of easy. There's the one, I think we have one coming up where there's a lot more now. There's one that's got like all the mutations, but this is the big ones to kind of remember: the APC, the KRAS, and the P53. And it just kind of goes along there. And this takes about 8 years to happen, is what we think, which is where sort of the screening protocols come from. If it is, let's see, yeah, this goes through into the details of the cell signaling, etc. This is just stuff that, you guys go over this and you'll learn, remember it right before the test kind of thing. MSI is a different pathway that it comes from. Now this gets confusing. I spent a lot of time with my residents, I don't think are on here talking about this. MSI, there's kind of two ways we talk about it. One, either in the patient's personal DNA, not the tumor DNA itself. If you have that, then you have Lynch syndrome. If it's in the tumor but not in the person, then that's what we call a microsatellite unstable tumor. That one is a good. The big news now in the last 5-10 years is that it's a good target for immunotherapy. So that's where you'll hear that come into play a lot more. Pre-op evaluation is actually still pretty standard. It's been the same for a long time. Of course, this is kind of the oral board sort of thing. I do a complete physical exam. Lymphadenopathy is kind of a little bit silly because, a tiny fraction will have palpable lymphadenopathy, and of course not much on an abdominal exam. Certainly if it's anywhere near, the rectum, or your GI doc tells you that someplace in the sigmoid, rectosigmoid, you're going to want to do more than a DRE. You're going to want to do a rigid proctoscopy, just to prove it's not in the rectum, because of course we treat those cancers differently. Lab CEA is still valuable, although increasingly less so. We use a lot of circulating DNA now, which is done after the specimen is out. Of course, CBC, CMP to prepare for the surgery itself. And then certainly, this still kind of takes a long time to get out there in the public, but certainly staging in terms of doing the TNM staging, the CT of the chest, abdomen, pelvis. So the test used to say a chest x-ray is okay, but I don't think that's true. I know it's not true anymore, and hopefully the test knows it's not true anymore. So a CT, chest, abdomen, pelvis. And then for local staging, if this is a rectal, you won't get a lot of rectal cancer questions in my experience. The ACS and general surgery and stuff have kind of pushed that off onto the colorectal specialist. But if you do, it's absolutely standard now for an MRI of the pelvis. For local staging, we do a pretty good job of guessing at lymph nodes in the T stage from that. Endorectal ultrasound used to be one of those things, and some regional places will still do it, but it's much, much more standard now to do the MRI of the pelvis. You guys can look this up as well as anybody. It's pretty straightforward, the TNM staging. It's basically, 1 and 2 are through the different layers that you can see there. And then T4 is when it invades into another organ. That's the big change. That would change what you do for colon cancer. N is, of course, the lymph node stage. And it's basically 1 lymph node is N1A, 2 is 2 or 3 is 1B, and then more than 3 is 2A or 2B. And those the big thing for that is that postoperatively in colon cancer, if you have positive nodes, most patients will benefit from some adjuvant therapy, typical chemotherapy, either FOLFOX or FOLFOXIRI, some 5-FU based sort of thing. And then, as I said, we have now adjuvants like immunotherapy as well. Metastatic disease is not a death knell for colon cancer. I always tell my patients, if you're going to have metastatic disease, colon cancer is one of the best ones to get. Because we have a lot of people that we cure with metastectomies, etc. And of course, you want to be careful in who you choose for that. But this is sort of a representation of that. If it's localized, most people are going to be cured, and then less so as it go on. So here's kind of that brief of that. If you think it's stage 1 or 2, meaning you don't think there's any lymph nodes, you do surgery. As you can see, we're not really good at guessing at lymph nodes before surgery on CT or PET or anything like that, so that usually doesn't change. So if you, as long as you don't think it's metastatic, typically surgery is going to be first line, of course, after the patient's optimized, after they're been cardiac cleared, etc. But then you would add adjuvant after that if lymph nodes are positive. Typically, if you're stage 4, I think for the test, my answer would be I would do a systemic agent first and then consider synchronous surgery. We used to be really careful with that because we weren't so good at sort of liver surgery, etc. Now it's most of the time I would say if a patient is young and healthy-ish, synchronous surgery to take out both is not a bad plan, sort of thing. And then this is kind of getting into the nitty gritty. Most T1s and zeros, T2s and zeros will not get adjuvant therapy. T3s, many won't, and what we're at now is that if there's pathologic bad signs, basically poor features, what we call it, so basically if there's lymphovascular invasion, if there's a high degree of tumor budding, etc., then you would think about a couple of months of chemotherapy. Radiation is almost never used. Oh, that's for rectal. Okay, radiation is almost never used for colon cancer. Why? Well, things in the upper part of the abdomen don't take a joke from radiation. In the pelvis, it's okay. Things around it aren't quite so susceptible, so we can use it there. And then kind of go from there. So this one is the talk about rectal cancer. As I said, it's a big subject now. It'd be its own talk, and as I said, they really don't like that. It's my understanding they don't like to focus on it too much. You just want to be careful. As I said, I think the big questions will be differentiating a distal colon cancer from a rectal cancer, and kind of whether or not you can go down your own pathway of the colon, or do you need to pass it on to somebody who knows how to deal with rectal cancer. How do you do that? Well, as you said, the proctoscope, and then an MRI can tell you if it's above or below the APR, the abdominal perineal reflection. If it's above, you probably don't want to do a raw radiation, treat it more like a colon cancer. If it's below, then you can treat it more like a rectal cancer. And for the most part, what do we do now? Well, a lot of patients will get neoadjuvant therapy. We don't even call it that anymore because about 30-40% of patients will go on to watch and wait, which I put down here. Watch and wait is non-operative management of rectal cancer, and this is relatively new in the past 5, 7, 8 years. So be another one. I don't know what the test was like the last year or the year before, if this was even included on that. It's not controversial anymore for sure, but it is still kind of in that category. And then this kind of goes through that. Again, I wouldn't go crazy understanding this. Just know that anything that's locally advanced in terms of rectal cancer is you're going to want to do neoadjuvant therapy before surgery, and then consider surgery after the treatment there. And then, as I said, that's associated with improved local pelvic control, kind of local control from that. Let's see, doing it beforehand. This is one of these things. Historically, we used to just cut it out, and then people get radiation afterwards. But it's bad to radiate. You're new anastomosis, etc. So we've learned over the years if you do it before, that's just fine. And then occasionally, as I said, you can get a complete response. The important thing about when you do surgery for rectal cancer is to do what's called a TME, or total mesorectal excision, and that's staying in what we call the holy plane of healed, famous British surgeon, and that's right. I don't know if you can see my pointer, but it goes right along sort of the sacrum there, and you're making sure to include all the mesorectum. You actually get judged on that, and it's a indicator of how well a patient will do afterwards. Is the completeness of it, like what it looks like. So just like taking a picture of it, kind of thing. And here's a good picture of that. So you can see the left picture, this nice, they call that the mesorectal fascia. Of course, it's not real fascia, so that's nice and intact. The middle one has a couple of spots maybe where it was impinged upon, and then the right one is not so good, so it's all impinged. So how do you decide to do an LAR versus an APR? I trained at the Mayo Clinic. What I was taught there, if you can put your finger up and you can hook it underneath the tumor, there's a pretty good chance you're going to get a negative distal margin, and you can put the patients back together with good control. So it's pretty straightforward like that. Some people will use like radiologic sort of things to say, is it invading into the sphincter muscles, etc. And nowadays, we used to do pre-op imaging and operate off of that. Now we do post-adjuvant, post-neoadjuvant, post-treatment imaging. So it's okay to, if you've gained a little bit of a margin with some radiation or chemo, it's okay to use that. Most patients with an LAR will get diverted for rectal cancer because they will have gotten some radiation ahead of time, but not everybody. So this is one of these it's better a board question. You might get, if you get like on the ABSITE, it'll be pretty clear. It'll be somebody that's been malnourished for a long time. They're actively on chemo. etc. Certainly, if you're radiated, you should get diverted. But I think for the most part, you guys hopefully have a pretty good, sort of way to talk about whether you're going to divert somebody or not. And certainly, as I said on the oral boards, most people are going to be pretty careful with that. Local excision for rectal cancer, I wouldn't go crazy talking about because again, this is a little bit controversial. You're only going to want to do that if you're pretty confident the patient does not have any regional disease, aka no lymph nodes. How are you pretty confident with that? Well, it turns out the T stage relates very closely with the end stage. So T1 tumors have a pretty low chance, about 5 or 10% chance of lymph nodes, but it's still in that range. T2 goes all the way up to 20%. So if you're sure that it's a T1 tumor, and especially if it's an older person, etc., a local excision is probably okay. But anything higher than that, you want to be real careful with because you're missing. You don't know if you have lymph nodes or not. So that's kind of the key one. How do we do it? We'll actually do it robotically now. This looks like a laparoscopic kind of view, so we do it with the robot and carve it out that way. That's not, not going to be tested on that. So this is pathologically, what do you want to make sure is tested? So this was a question I think I saw. MSI testing now, I would argue, is standard. It really has to be standard. This is the microsatellite instability. They're gonna, if it's an old question, they're gonna lead you down. Does it need to be tested? If you're concerned with Lynch, but I would certainly argue, and I think it's probably standard now on the test to say that's a requirement for every patient that has colorectal cancer. Why? Because again, we have a whole different treatment modality, the immunotherapy agents that can be there. And then after that is surveillance. It's pretty standard. It's you can see the NCCN recommendations, but for the most part, depending on the stage, you want the patient to be examined every 6 months, CEA every 3 to 6, and then some sort of imaging. Colonoscopy at a year, and then actually after that can be spaced out. Hereditary stuff, this is like one of these things they love asking questions on, and like you almost never see it in real life, but it's like, it's just something to kind of, study up right beforehand. Basically, it falls into polyposis or non-polyposis. So if they give you a patient with like hundreds or thousands of polyps, that's going to be FAP for dollars to donuts. If it's just somebody who has like an extensive history of colon cancer in their family and they're very young when they have it, that's the non-polyposis, almost certainly going to be a Lynch kind of thing. So FAP is like thousands of polyps. MAP is mut-YH associated. That's like a lesser version. It has like hundreds of polyps. And then these other ones, just remember that they can be associated with the other weird kind of tumors like hamartomas, etc. And then there is a serrated polyposis syndrome too that's involved there. So you got to be careful with those. What do you do with those? And here it goes down through. You guys can look over this. What do you do with these different things? So FAP, autosomal dominant, but doesn't penetrate everybody. So that's kind of the important thing. Not everybody in the family is going to have it necessarily. Here you go, hundreds of thousands of polyps. There are some subtypes. Gardner's is the kind of the famous one with the desmoids and the different things on the teeth, etc. Turcotte's is the one that has malignant tumors. I got to say, I've been practiced 11 years, and I've had one FAP patient, 1 or 2, and they've not had any of these. So I saw this picture when I came through. I was like, wow, that's really gross. They decided to cut like a desmoid in half to show you that there. So FAP, almost everybody will get colon cancer. So this is the big one. You like to do a couple of things. One, I think that's the next question there. You like to do a colectomy on these patients to decrease the risk, and usually you wait till kind of their 20s, you get young 20s if you can. And we'll talk about what it exactly is to do. And then just remember that it's associated with other things. So there are upper GI tract cancers that can develop, typically the duodenal and periampullary ones, and so those patients need EGDs on a regular basis. And then as we talked about, desmoid, even thyroid, which you guys just talked about. FAP also can get pancreatic cancer, all those, so they got to be screened carefully for those. And I would say, just argue, you could say send for genetic testing. These other ones are not going to be real important. The big one for surgery for this is you want to remove, certainly the colon. It's the question of whether or not you are going to have to remove the rectum too. As you guys know, you certainly can remove the rectum and create J pouch or IPAA, ileoimmune pull through anal anastomosis pouch, but there's a big difference in function between those two, so we really like to leave the rectum if you can. It's much safer for the patient in the long term as well, and less problems as you go. So the rules are basically, the phrase that we use is if it's rectal sparing, quote, rectal sparing. So if you can clear the rectum and that can be done often easily without sedation with a flex sig or something, and you're pretty confident. There's no specific, this says number of polyps like 20, etc., but for the most part, I would say is like if you are pretty confident that you can get this patient in and be cleared, you don't need to do it every couple of weeks or something like that, then certainly a total abdominal colectomy, not a proctocolectomy, is fine. So usually, as I said, you wait late teens, early 20s to let them be big enough, and then you do that. Lynch syndrome, I guess that's Dr. Lynch. Long story short, 3 to 5% chance of colorectal cancer. It's also autosomal dominant. It tends to be much earlier. Very common to have metachronous tumors, and there are, of course, other sites that have to be screened carefully. Endometrium is kind of the big one for that. This is going to be outdated. Again, it's hard to know they're going to ask this kind of stuff because I haven't thought about the Amsterdam or the Bethesda criteria in a long time because now we have, of course, genetic testing for Lynch, and so this will kind of go into this to some degree. Of course, I would say the Bethesda criteria are the ones to look at for now, and just kind of have glanced at that before the test in case it pops up. But for the most part, we do a pretty good job by just the genetic testing now. And yeah, we kind of talked about this here already. So some of these subtypes, again, I want to go crazy into those. We're not going to waste our time on that. Again, total abdominal colectomy is the one that's favored for this kind of thing. And then most patients, especially if they're not childbearing age anymore, recommended THPSO just because of the high risk of endometrial cancer. Okay, I'll pause there real quick. I know probably nobody feels comfortable stopping me to ask questions or anything, but is there any questions on sort of colon cancer, colorectal cancer?
You mentioned briefly about clearing the colon and feeling safe to do a total abdominal colectomy versus, the proctocolectomy with the J pouch. Can you clarify what you mean by, like, is there like a standard, like, if there's less than a certain amount of polyps in the rectum?
Yeah, so clear the rectum, yeah, not the colon. So
Okay.
yeah, you'd want to make sure that what you're leaving behind isn't just going to develop a cancer, in 6 months or something like that. So no, I think on that slide it had less than 20 rectal polyps is what's there, and I don't know that there's a standard thing. I think I just had a patient with this recently. I think it's more like if you got a patient that like every 2-3 months needs a flex sig to make sure that the polyps are out, then that's going to be a problem, because what happens if the patient doesn't show up, for one of those, they get sick or their kid gets sick or whatever. So it's more, I think, a balance of, is this a reliable person that we're going to be able to detect if there's an advanced polyp, before it becomes an advanced polyp, I should say, and remove that in the rectum. And it's just because it's so much easier to screen the rectum. You do it without sedation. You poke in to the office for 15 minutes and you're out. So no, I don't think for the testing sake there's going to be a specific number. It'll be a question that's something like, you have a young patient with hundreds of polyps, and then they'll either just use the phrase rectal sparing, or they'll say with relatively few in the rectum, and then there'll be an answer that's like frequent, total abdominal colectomy with frequent flex sigs versus total proctocolectomy, and they'll make it more clear. I mean, they're both good, both choices, but if it's they use that word relatively spared, I think that's going to be your trigger.
Okay, great.
Okay, anal cancer. I always tell my residents and stuff, this one's relatively straightforward for us because there's not a lot that goes into the decision process for this. This is squamous cell. It's pretty darn rare. What is the highest group of people that have it? HIV positive people, especially those that are poorly controlled, but any HIV has a higher risk of that. And really where we play a big role in this is sort of screening patients that are at higher risk for it. So you can see here's the well, I guess that's just the total incidence. It's actually still extremely rare. HPV is the big one for this, right? So basically, the way I think about HPV is that it's a necessarily intracellular organism, virus that lives within the squamous cells of this area. That's why you don't really get HPV much of the colon. And they can live there for a long, long time. and then for whatever reason can get activated and create growths and problems, right? So for the most part, they're going to be condylomas. Condylomas have no dysplasia, are slightly higher risk than not having condylomas, but still very low risk, probably just more a marker of having HPV, and then that can turn into something called AIN, or anal rectal dysplasia. We used to call it high-grade intraepithelial neoplasia, the HGIN down there. I should have changed that. We now use the term AIN, anal intraepithelial neoplasia. Basically goes 1, 2, 3. The higher up the number is, the more risk it is, kind of thing, and the more careful you want to be. And then I guess smoking also plays a role in that. It's pretty straightforward, as I said, how we deal with this. It's basically what I talked about. I mentioned the anal verge before, because that's where this comes into play, especially for how these cancers are treated. So if you spread the patient's buttock apart and you can see the tumor entirely on the outside, then it's an anal margin tumor. If that tumor crosses into, or you can't see it entirely, then that's an anal cancer. Now, why does that play a difference? Anal margin cancer, we treat like a skin cancer. Anal cancer, or anal canal cancer, you treat like an anal canal cancer, I guess. So the anal margin cancer, you do your very best to cut it out as best as you can, just like any sort of skin cancer. You still have to be concerned for lymph nodes, etc., but that's where the big difference is there. And then, as I said, this is the one where the lymphatic spread is actually important. I mean, it's an important part of follow-up as well, and for diagnosis initially is to make sure that you palpate the inguinal nodes, because that's where they come from. And so, of course, a huge majority of people present late with anal cancer, the embarrassment, just thinking it's just hemorrhoids. I mean, all the time we'll have somebody that's been seen by primary cares like 20 times and like they don't get diagnosed with this. So that's the biggest kind of thing. So it's higher incidence even with good control of your viral loads. What's the treatment? Well, again, so anal margin you cut out typically and move on. For the other one, immunocompetent. Yeah, so for the most part, the next. Sorry, this is the staging. The staging is by size. We'll typically use either MRI or CT for that, and then the lymph nodes and the distant mets are the big ones. So that's pretty straightforward. Before we get to the treatment, I guess. So the workup, you want to obviously take a biopsy to prove that it's squamous cell cancer. This question of sort of sphincter involvement. So that would be for like an anal margin. Almost all anal canal cancers are going to have sphincter involvement because the sphincter is just below the mucosa, of course. So that's where that kind of comes into play. And then, as I said, CT, chest, abdomen, pelvis, MRI. Colonoscopy, I mean, I would argue is a little bit silly because this has nothing to do with colon cancer. And then they say a GYN exam too, because of course there can be crossovers between the two because they're both, the HPV is risk factors for both kinds of cancer. So this is the big one. You know, again, if this was 50, 60, 70 years ago, this question would be more interesting. But now it's absolutely standard for chemo. We call it definitive chemoradiation, or everybody knows it as the NIGRO protocol. So this is one you should memorize. This is one of these protocols that it's just good that you might get buzzed on. So mitomycin C, 5-FU, and then about 5,000 rads to the primary tube beds, and a lot of times they'll boost the inguinal nodes for that. And the inguinal nodes should always be included in the radiation bed. That's one of the questions that will come up sometimes. Do you have to? You should do it even if you don't think there's positive lymph nodes, just very little downside to it, sort of thing. So a huge majority will respond. Something about 90% or so will respond. And as I said, this is where it's not all that interesting to us as surgeons because it's pretty straightforward, the decision tree, what to do. So if patients get definitive, if it's anal cancer and you get the definitive NIGRO protocol, you wait, and then you wait longer, and then you wait longer. So that's going to be you're going to get a question on this. I think I have a pop quiz question at the end on this. So it's basically if somebody comes back just after radiation, you put your finger and the tumor's still there, the answer is wait, and just wait. How long can you wait? I mean, I think 6 months is sort of reasonable. Some people will wait a little bit more if it's closer to it, but I would say about 6 months is reasonable. And then if it's still there, or you're not sure, you would take them for an anal rectal exam under anesthesia and take a biopsy. If the tumor is still there after whatever time period, you say 6 months sort of thing, then the next step is an APR. Pretty straightforward kind of thing. Salvage rate's 50%. I suppose that's probably true, but what else are you going to do? So that's, as I said, it's pretty clear on here. You can see that stuff. Okay, appendiceal. Okay, so Appendiceal anatomy. So an appendix is like a true diverticulum to some degree, I guess is the way to think about it. It has all the same layers of the wall as the colon. This is one of these, they love asking these questions, although the decision process is pretty straightforward. So the vasculature, they say the appendiceal artery, but of course that's really the ileocolic artery, as you can see there in the SMV. Appendiceal neoplasm, so cancers that are in the appendix. This is almost always going to be asked you, like you do an appendectomy and the pathology comes back as something. So keep it in your mind. It's about 1% of appendectomy specimens, so it is relatively frequently. What kinds can you have? You can have an epithelial neoplasm, so that's usually a mucinous kind of thing. That's really more of like either an adenocarcinoma or like a mucocele. And you'll see that. You probably have seen something like this at some point, some kind of mucinous aspect to it. For the most part, your job with a mucinous one is to decide if it's low grade or not. If it's low grade, you're pretty happy about it. You don't need to go crazy with treating it like a big bad cancer. If it's high grade, you just treat it like a colon cancer. That's pretty much all there is to it. The low grade ones can, of course, cause problems with mucinous throughout the belly, but as long as you do a good job resecting it early on, you should be okay. And they grow very slowly. Kind of thing. Mucinous adenocarcinomas, this is what they say. They used to call it high grade, now they just changed the name of mucinous adenocarcinomas to encourage people to do straightforward surgery. The big one with this is that mucin, when a pathologist, you might get this question where the pathology will say something like mucin is deep within the layers or beyond the basement membrane or the muscularis propria. So if that's the case, then that's essentially mucinous adenocarcinoma. The mucin is not where it's supposed to be. And that you treat like a real colon cancer sort of thing. Now this one is the one that can cause you the pseudomyxoma. There's not, I doubt they're going to ask questions for that because that's just one of those things that's when it happens it stinks and you just got to deal with it. But there's not a good way to ask kind of questions on that. Then regular adenocarcinoma is, I don't know, it's just about the same. That's the pseudomyxoma there. So long story short with this, you need to do the so if you get this referred to you, you get this on a pathology specimen afterwards, make sure you do the full workup, just staging workup again, the CT of the chest, abdomen, pelvis, just like you would colon cancer. There's really not much to that. And then, I guess it doesn't, I don't know if we talk about it, but basically you treat this, as I said, like a colon cancer. If it's a T1 adenocarcinoma with the T stages on the pathology specimen of the appendix, patient needs a right colectomy. Why? Not so much that you're nervous about whether or not the tumor is out entirely. You might still be nervous if you have a positive margin or something like that. But the truth is you don't have a good lymph node dissection, so you don't know whether the lymph nodes are involved. So I would say if you get a question on appendiceal adenocarcinoma, you should do a completion right colectomy to make sure you have the right, even if the margin is negative. NETs are different. This is the one where the questions often lag behind sort of what we do. So neuroendocrine tumors, used to call them carcinoids. We don't call them that anymore because of trying to name things from where they come from. So neuroendocrine tumors, of course they can be active in terms of their endocrine, but it's a pretty rare chance. They often look rubbery, kind of lipoma-y like that, and what they might give you is the histology that you see there, instead of just telling you it's a neuroendocrine tumor, or they might give you those stains. The chromogranin A is sort of the big one that they use, and then the big one for kind of NETs is Ki67. The grade of the NET is kind of the most important thing. It's even more important than like size and stage and whatever. So if it's a low grade Ki67, you're pretty happy with it. If not, then you get more nervous about it. How do you diagnose? Well, most of the time it's either seen like this or you get specific imaging. You can get a dotatate PET for NET. I say can get because most time insurance won't pay for it, but that's a specific for a neuroendocrine tumor, and then maybe you can see it on colonoscopy. But as I said, a lot of the time you're going to get it from the appendix sort of thing. So this kind of goes into this. Long story short, a mucocele you should not, unless it's throughout the abdomen, you should not need to worry too much about that. Carcinoids, that's the size that matters. So 1 centimeter is still sort of the cutoff. We're pretty much okay with an appendectomy for one to two is sort of up in the air, and then if it's bigger than two, you want to do a full segmental resection like a right colectomy, and that is really more. It's very rare to have lymph node involvement. So it can happen, and so that's where that comes into play. So that it is lymph node involvement there. And then this talks about cytoreduction, HIPEC. I think it'd be very unlikely to get a question on this because most centers don't do this, or many centers don't. But the idea is if you have a relatively low-grade tumor that is not metastatic, you can try scraping it off of every place in the belly. So I don't know if you guys have a lot of experience dealing with this, but there's sort of grading systems for it, etc., that you can use looking at that. And again, I doubt that they'll ask. It's just good to be aware that it exists. Lymphoma is pretty straightforward. Every year there's going to be one question on this. If you know for sure it's a lymphoma, the deal is just decide if it's in the rest of the body or if it's localized. So this is different than sort of the gastric lymphomas and stuff, which you do different things for. So in the colon or the small bowel, we still typically will take these out, kind of thing. So it's one of those, we used to kind of go back and forth. Should you give, some sort of chemotherapy, usually CHOP first, but no, I mean, unless it's systemic and you have it everywhere, it's a good idea to cut it out, and then, we'll then treat it from that after you got it out. Gysts, similar elsewhere, sort of in the body, in the stomach and whatnot. Gysts come from this. This is one of the ones they love to give you the histology for. So the spindle cells and the CD17 KIT positivity kind of thing. So most commonly in the stomach, sometimes small bowel, and then one of the big ones for us is the rectum. They're all the time in the rectum. So the long story short for this, these are these kind of rare ones, but you try to do your best to remove them. If it's in the rectum, you can do transanal excisions for that. So you're trying to get a negative margin. We say 1 centimeter. This is one of these things you learn over time, that margins are kind of bullcrap unless there's some very good reason for it. So 1 centimeter, you just want a negative margin for that as best as you can. And then those that have high KIT positivity will get systemic treatment as well to decrease the chances of it coming back. Those that have low KIT will not get it. So if it's in the small bowel or colon, do a segmental resection. If it's in the rectum, you can try to get away with a local excision. I think we can skip over this. Melanoma, it's bad in the anus and the rectal area. Nowadays, we use a lot of systemic treatments for that, and we try not to cut it out because it's not really a local problem; it's a systemic problem. These ones I wouldn't even worry about. So, okay, I'll pause there for the cancer one as well. How am I doing for time? I have like 10 minutes, right? Am I supposed to be done at 12:40? Nobody knows. Okay, well, I'll keep going. Anybody have any questions on oncologic? Okay, we'll zip through this. So benign disease, grab bag of small bowel questions. I like this. So what's an SBO and pneumobilia? Nobody's gonna talk today, are they? They're all like doing something else. Okay, so that's probably dead gut. Right, so you want to be careful with that. You want to get to the OR. Malt in the mid-jejunum, take it out. Stomach, treat this. Of course, I'm not a stomach expert. If you have in the malt in the stomach, treat the H. pylori in the small bowel, resect and observe. I guess.
Apologies for hopping in. You have until 12:40. 12:30. 12:30 is break.
12:30. Oh, that's like now. Okay. Well, then let me run through. Meckel's you don't take out unless it's symptomatic. And we'll jump through these guys. Cecobasculal. Gosh, I spent way too long on the cancer side. Cecobascular is the bean. What do you do for cecobascular? A right colectomy. You never tack it down. That's what this is showing you. Sigmoid volvulus. What do you do for that? You detorse it, and then the answer in all the tests is to do a sigmoid colectomy if at all possible during the same hospital admission, so it doesn't come back again. Diverticulitis, you guys spend tons of time on this. It pretty much comes down to, do you need to operate straight away? If you need to operate straight away, you can put the patient back together and divert above it. That's fine, although Hartmann's are more common. If it's complicated disease, aka has an abscess or a fistula, they should eventually have surgery. If it's uncomplicated, you don't need it, and you don't need antibiotics for uncomplicated disease anymore. So just clear fluids. Big distended gut in an old sick patient that's in the cardiac ICU is Ogilvy's. you guys have treated this before, just run through the treatment of that. Biggest thing, and I totally agree with this, you're going to fail your oral boards if you don't make sure there's not a distal obstruction. So do something with some contrast up the bum, and then neostigmine, etc. Just make sure they're in a monitored area. Very rarely do we need to do surgery on that. GI bleed, I'm not going to spend a lot of time on. You guys do this all the time. Ischemic colitis is a similar thing. You guys know how to kind of treat that. C. diff, this is one you guys, again, I know spend a lot of time treating. The answer nowadays is you just got to know the pathway on how to treat this. So it's oral vancomycin now, then fidaxomine, and then a fecal transplant. If the patient is doing poorly, what operation you do? Never ever do a segmental colectomy to a total abdominal colectomy and ileostomy. So that's the kind of the important. They'll talk about lavage and stuff, but it's like really don't get tricked into that, especially for your oral boards. We won't spend a lot of time on IBD. IBD, I think, is really in the realm of colorectal surgery. Just know the difference. The big difference is between Crohn's and ulcerative colitis. Ulcerative colitis starts at the bottom, goes its way up. It's cured by a total proctal colectomy. Crohn's disease is not. And so just these are the ones you guys know well from medical school. Just let me make sure I'm not missing anything big. And then you guys will, I think you guys will get this sent out to you. You know, we don't need to spend a lot of time on the anal rectal stuff. You know, we try not to operate on hemorrhoids anymore. If you do, you do hemorrhoidectomies. Most of the time we can get away with office-based procedures. Fissures you typically treat with nifedipine or something to increase the blood supply, the blood flow there. Lots of warm baths. Abscesses, this is, you guys I know spend a lot of time on this. Just make sure it's really drained properly that first time around, especially in the deep postanal space, especially if it's going around to the side. Yuck, look at that. So this is the modified handling. So you do that posterior drainage there and get into the, go through the internal sphincter to make sure you enter the deep postanal space. That's the phrase you want to see on there. And then good drainage after that. Fixing fistulas is much more colorectal kind of based. Pilonidal, I doubt very much you'll get. It's an acquired disease, and go from there. Okay, and then I put a bunch of questions on here. You guys can go through these and do these because we're kind of out of time on your own there, but it sort of hits what we talked about. Okay, sorry to run a little bit over. Questions for me, please. I thought this was really boring, just me talking at you for a while, but let me know if you have any questions. Yeah.
If the residents don't have a question, I'm asking on their behalf. Because I feel like I've seen this. Can you talk a little bit, just hammering about the handling procedure, sort of the good salt rule,
sure.
High yield for...
Yeah, let me see. Did I lose my slides? Here we go. Let me get it back up here real quick. You guys still seeing it?
Yes.
Okay, I'll get back to that picture. So, okay, so this is, I agree, this is probably a good one to spend a couple seconds on. So, all anal rectal abscesses, except for those associated with Crohn's disease, start at the dentate line, where they come from crypts. It's called cryptoglandular. So it always starts here and then will spread into the tissue around the anus, and this is typically because of the high pressure of the internal anal sphincter. The internal anal sphincter's pressure is above your mean arterial pressure. That's why we get fissures to begin with. And so because that pressure goes high, it squeezes it into the tissue that's there. So when you have a abscess, that's a horseshoe abscess that goes around like this. So your goal on your oral boards or on this test on the ABSITE, anybody that has pus in their bottom, it needs to be drained. It needs to be drained as soon as possible, because otherwise it's going to turn into the Fournier's gangrene, etc. So the answer is always going to be drain it, period. Now the question is, how best can you drain it? So a big hole, never make one little tiny dot hole. That's what ER doctors do. That's not what we do. So make a big hole that the pus can come out of. Nobody has ever been made incontinent by draining somebody's pus out of their bottom. I can tell you that. You could get incontinent by a fistulotomy or something afterwards from that, but it's never happened because the pus is not in an area where the external sphincter is. So when you have a horseshoe abscess, or if you have pus on both sides, this is one of these anatomic things that it will necessarily, once in a while it get something really weird or superficial, but 98% of the time it's going to need to go into this area called the deep postanal space. So the deep postanal space is between these ligaments, the anal coccygeal ligaments. So there's two of them that are here. You can see, really we just think about this one main one here. These deeper ones, I wouldn't worry too much about. These are kind of crazy ones. But this is where it says that deep postanal space. that's where you want to make sure you enter. My residents know whenever they call me in the middle of the night that 99% of abscesses can be drained by the bedside, and you just do it and I go back to sleep. But the ones that can't are the ones that are horseshoe abscesses. Why? Because it's almost impossible to get into the deep postanal space unless you got a really nice compliant patient that's ready for you to jam something in there, because it's like basically popping through fascia. So those are the ones that have to go to the OR to make sure you enter that. So this is where this posterior wound comes from. You make that posterior drainage, you enter the deep postanal space there, and then the counter incisions are just to get the pus out. So the old Hanley procedure was actually cut that went all the way around like this, trying to stay along the groove of the external sphincter so you don't make them incontinent. We learned over time, no, we can actually do what's called a modified. This is technically a modified Hanley. So you make counter incisions just to the place so that there's not kind of pus collecting here and it's not going to make its way out. You do something to treat the posterior midline. So either you leave a ceton in there or you do a posterior fistulotomy, kind of like they did here, and then you leave draining cetons that go laterally to the middle here. And those, as I said, are just to keep this open so this stuff comes out, the pus comes out. Then when they come back to see you in the office later, you can remove these draining cetons, and as long as you've done either a fistulotomy or have a ceton in the posterior midline there, you've treated that area, that you can move on and it should get better from that. Now some people will say just leave that ceton in there, let all this settle down, then you can do a posterior fistulotomy easily because there's very little external sphincter posteriorly. So that's the other thing that you can do. But the key there, the key kind of phrase, especially for oral boards, is like I want to make sure I enter the deep postanal space and that we drain everything appropriately with the counter drainage. What you're talking about for Goodsall's rule, Goodsall is surgeon like almost 100 years ago. There's a line that goes across here. I don't know if you can see my my mouse or whatever, but the line that goes, you can, okay, it goes right across kind of the middle here. And this is something, they actually studied this recently, and Goodsall's rule, it only follows it's something like 60% of the time. So it's not a particularly good rule, but it's good to know. Anything posterior to this, so kind of on the top of the screen, tends to go straight in. Anything anterior to this has a much higher chance of arching around to the posterior midline. So if I evaluate a patient in the office, it doesn't mean they always do, but if I evaluate a patient in the office and you've got a fistula that's anterior, you kind of stick a probe in to get a sense, is it going straight in which case it's a straightforward fistulotomy typically. If it arches around like this, then you're going to want to take the principles of a Hanley and do the kind of the same thing. So what I would typically do for that, and this might be more than you need to know, but you would do a posterior fistulotomy, leave a draining ceton in, and like kind of like you do for the Hanley here, wait for this posterior fistulotomy wound to heal, and then remove the ceton in the office. So that's Goodsall's rule. Line here, anteriorly, it can arch around to the back. Posteriorly, it usually just kind of goes straight in, and you have to check less for the arching.
Thank you for hammering that part in. I feel like I've seen that on a couple of episodes.
Good. Yeah, good.
Okay, great. Thanks so much again, Doctor.
Awesome. Yeah, thank you, everybody. I think I left my contact info on there, too, so I'm certainly happy to answer any questions or whatever if they come up. Appreciate it.
Thank you. All right. We eat into your break a little bit, but feel free to grab something to eat, etc. We've got Dr. Ian Greenwalt, who is a breast surgical oncologist down in Virginia now. Thanks so much for being here. Let you go ahead and pull up your slides there. Breast is definitely a high yield topic on the ABSITE. It shows up everywhere. There are a lot of pathognomonic things, sort of key flash words that I think can be really helpful. So this is definitely one to not miss. Thanks, Ian, again for being here. Appreciate you.
Yeah, of course, Dr. Leamy. Thanks everyone. Let me just get this into presenter mode. If there's ever any issues, sorry. Okay. Yeah, if over the course of the next 30 minutes, so if you guys ever have any issues seeing my slides, please let me know. As Dr. Leamy mentioned, I try and distill this down because there's a lot of info, but hopefully you guys can pick up a fair number of points on your ABSITE and then maybe a little bit on written boards as well through some of the stuff I've highlighted here. So apologies if we go relatively quick and hit on a lot, but you'll see it at the beginning, seeing at the end in terms of the stuff to really kind of spend your time on.
Ian, your slides aren't up yet.
Oh, okay. Let me do that.
They were, and then they disappeared. Looks funny. Maybe swap screens.
Any better now?
Mm-mm.
No.
It's just showing a weird background.
All right, let me try one more time. Sorry.
All right, it's getting there. Nice. You're right.
Better?
Yep.
All right. Okay. All right. So, just some general objectives here, but hopefully hit on the high stuff, some things you guys can take away to grab a few points on ABSITE, then also stuff that's relevant for boards too. Just a few plugs here. I'm sure some of this still applies, some of it may be a little bit antiquated, but these are the things that I used in terms of getting ready for ABSITE and for boards. I still think clinical scenarios in surgery. I use Behind the Knife. I'm sure they've upgraded it quite a bit since then. CSAP and then Osler. I am not a paid spokesman for any of these things, so no conflict of interest there, but just things I found to be helpful. So you're going to see this again at the end of the presentation, but these are the things I'm going to try and highlight throughout. So we'll spend a little bit of time on benign lesions, particularly those that need to be that are operative. So particularly atypical ductal hyperplasia and pleomorphic LCIS. You know, the general approach to cancer workups can get very convoluted, but the general concept of naming it, staging it, and treating it in terms of what is considered to be a complete oncologic operation. So in terms of margins, axillary staging, and then talking about the roles of managing the axilla in particular, knowing what the BIRAD system is, understanding you don't need to memorize staging per se. That's not really high yield for you, but just kind of understanding the different points where management changes in staging. And so try and break that down in terms of early stage disease, that we're managing with surgery up front versus more locally advanced disease and how that impacts management. DCIS, changing a little bit from invasive disease there in terms of how we approach that. With invasive disease, the buzzword there obviously is no tumor on ink when it comes to margins. And as opposed to DCIS, the margins there being 2 millimeters or more. So definitely bank those because I found that those popped up on ABSITEs almost every year. This is relatively new for this lecture, but I think now that it's part of standard guidelines in terms of NCCN and standard practice, targeted axillary dissection. So I think if you're not seeing it this year, you'll probably be seeing it in coming years on your ABSITE. So we'll go over that, as well as the role of axillary node dissections. Important to know the indications and particularly contraindications for breast conservation therapy, because that's something they really want to hammer in and make sure you guys understand. Inflammatory breast cancer does pop up from time to time, and an important thing to be able to identify and know the basic steps for managing that. And then lastly, occasionally they'll slip in a few questions about systemic therapies like endocrine therapies and chemotherapies. So don't have to spend a whole lot of time on that, but good to have it in case there's a random question here or there about it. So let's get into things. So in terms of benign breast disease, so mastitis versus abscess, most causes of mastitis tend to be Staph aureus. You can usually treat that safely with oral antibiotics. If you have recurrent unresolving mastitis, that should be a red flag, and that's they're trying to kind of walk you down the road of how do you work up and not miss inflammatory breast cancer. So someone who's been appropriately treated for superficial skin infection or mastitis, if it's not resolving, then yeah, the next step there is kind of think about inflammatory breast cancer and sample the skin. For an abscess, so most commonly associated with lactation, The recommendations there are oral antibiotics, continue to breastfeed, which decreases engorgement of the breast and helps with resolution of any residually infected material. Non-lactational abscesses, typically we'll confirm these on ultrasound, although clinically you can usually get a pretty good sense of what's going on. For smaller abscesses and someone who's not systemically ill from it, aspiration is an appropriate thing to do. But if there's any necrotic overlying skin, if it's a large abscess, if someone's having systemic signs of infection, then got to heal with steel in those situations in terms of draining the abscess and putting on appropriate antibiotics. Other things, again, not high yield, but sebaceous cyst, hidradenitis can also kind of masquerade in these categories too. The top image is showing, early, relatively limited mastitis as opposed to lower right-hand corner. That's clearly a periareal or abscess that you need to open up and then treat with antibiotics. Benign breast lesions. So there's a few different ways to think about this, but I like to think about it in terms of different categories of non-proliferative versus proliferative without atypia, and then proliferative or with atypia as well. The non-proliferative tend to be cysts with mild hyperplasia. Really nothing to get too concerned about there. But as we work through these categories, you'll see, the associated future risk of breast cancer increases. Hence the increased importance of understanding that, how it's going to impact screening and potentially surgical management. So when you get into proliferative lesions without atypia, intraductal papillomas, radial scars, flat epithelial atypia sometimes falls into this category. You'll see that risk increases by about 1.5 to 2-fold with these patients. So it's still a bit of a gray area, but I think it's pretty safe to say that a lot of these lesions now, the intraductal papillomas, radial scars, are not operative cases. Unless someone is an outlier there and they've got associated atypia with it, it's pretty safe to say that those patients, they may be higher risk, but don't necessarily need surgery, as opposed to this next category. So atypical hyperplasia, particularly atypical ductal hyperplasia. Atypical ductal hyperplasia is still something that we routinely operate on, and I'll get into the reason as to why that is. Atypical lobular hyperplasia, they are high risk, but usually don't need surgery. And then the associated increased lifetime risk in these patients is about 2 to 3x. So that's the reason why we spend so much time and effort trying to figure out how to manage these patients. And lastly, LCIS, so lobular carcinoma in situ, has evolved quite a bit over time. And so now, compared to the past, where we used to treat it as a cancer, now we consider it to be a non-obligate precursor or not a precursor, excuse me, to breast cancer. But it is a marker of significantly increased risk. So typically these patients, when they're diagnosed with LCIS, have around a 40 to 50% future risk of breast cancer. But it's not that those areas of LCIS are going to develop into cancer. It's just that their breast tissue as a whole is more prone to developing areas of abnormalities and future breast cancers in other places. The type of LCIS that they'll sometimes sneak in on ABSITEs or boards is a very specific type called pleomorphic LCIS. So that's the buzzword. If you see LCIS that is pleomorphic, that actually does behave much more like a cancer, like DCIS, and that is the rare form of LCIS that does need to be excised. So why do we care about these? So particularly with ADH, atypical ductal hyperplasia, the data tells us that there's about, depending upon what you look at and where your data is coming from, about a 12 to 30% risk of upgrade to an underlying malignancy. And usually we're talking about some DCIS or maybe a very small invasive cancer. But that's the reason why ADH is typically excised, is because there's some sampling area associated with the biopsy, and you want to exclude any occult malignancy here. With intraductal papillomas, radial scars, atypical lobular hyperplasia, and classic type LCIS, the upgrade rates we've found over time actually are substantially lower. So oftentimes in the low to mid single digits. So routine surgical excision of these lesions typically is not necessary. Shifting gears from benign disease into malignant disease. The general approach that I found very helpful, because it's easy to get lost in the weeds, and this is true for any type of cancer, colorectal, sarcomas, pancreatic cancer, but going back to this principle of naming it, staging it, and treating it is a good way if you're feeling a little bit lost. And so what we mean by that is, naming it in terms of, diagnosing it, getting tissue typically, staging it, figuring out how widespread it is, what types of studies, imaging do you need, and then treating it and figuring out, all right, what's my treatment modality based upon those first two steps in the process. And also, when you're thinking about cancer, and particularly on the surgical oncology side of things, you want to ask yourself, what constitutes a good oncologic operation for this type of cancer? So when it comes to breast cancer, we're talking about, are the margins adequate? And we're talking about, if lymph nodes need to be sampled, has that been adequate? So the naming it part of this. So I'll go through this relatively quickly, but you'll get very routine about this, especially as you're getting ready for oral boards, but getting a complete history and physical exam in these patients. Imaging, things to know. So the difference between a diagnostic and screening mammogram. Screening mammogram is for average risk patients with no active clinical complaints. A diagnostic mammogram is the next step. If something abnormal on a screening mammogram, or if someone's coming in with active complaints, you want to get a diagnostic mammogram. So in the workup here, if someone presents to your clinic and you're working them up because they have a new complaint, you're getting a diagnostic mammogram. And there's no qualitative difference. It just has higher detection rates because they can typically do additional views that day and also add on ultrasounds. There's fewer callbacks, and it just kind of speeds up the process. Ultrasound, often combined with diagnostic mammogram, for better classification, better detail on solid masses. And also, if patients have denser breast tissue, like heterogeneously dense breast tissue, they'll typically get routine ultrasounds for better evaluation of that tissue. Biopsy can be done in any of these modalities: ultrasound, stereotactic, which is guided by mammography, or MRI guided. And these are just some examples of things. So upper slide is showing benign breast tissue without anything abnormal on the mammogram. And then what a cyst typically looks like, it has round edges, is hypoechoic through the middle. And then if they put the Doppler on it, there's usually not any vascularity associated with it, as opposed to the lower images on the mammogram. You can see there's some increased density in the superior portion of that breast, suggesting a mass there. And it's a little hard to make out in the ultrasound here, but it's what we'd call a spiculated or stellate mass with some peripheral vascularity and a little bit of internal vascularity. So pretty stark difference compared to the ultrasound on the top. All right, this is worth spending a little bit of time on because you may pick up a point here or there on either ABSITEs or on written boards. Just knowing what the BI-RADS system is. I don't think you need to know every single detail or category of this, especially, the 4A, 4B, 4C. Don't worry about that. But just knowing the distinction in these different levels and where it impacts your management. BI-RADS 0 is something that is recommended if the radiologist sees something and they need additional imaging. So BI-RADS 1, BI-RADS 2 is associated with essentially a 0% chance of there being an underlying malignancy. BI-RADS 3, usually there's a very low chance of malignancy, but we're seeing those patients again in about 6 months just to make sure there's stability. But as you get into BI-RADS 4 and BI-RADS 5, these are probably the most important ones to know because these are where you start seeing increased risk of underlying malignancy. So if someone has imaging done, whether it's ultrasound, mammogram, MRI, and there's a BI-RADS 4, BI-RADS 5, there is more that needs to be done. And so typically we're talking about biopsy. And the reason for that is as you get into BI-RADS 4, BI-RADS 5, your risk of breast cancer, greater than 2%, we don't get too worked up about, but usually it's, the 4B, 4C, and definitely BI-RADS 5, which there's a greater than 95% chance of an underlying malignancy. So that's the buzzword there. If you see BI-RADS 4, BI-RADS 5, those patients are going to need some form of image-based biopsy. So malignant disease in terms of staging it. So a few other things to know as to how we stage breast cancer. So breast MRI, not always necessary. And I think it's kind of controversial, so I doubt that this is going to pop up on your exams, but just to know the reasons why we use it. Typically, for someone with a known breast cancer, we'll often use it to determine extent of disease, particularly with more diffuse disease processes like invasive lobular carcinoma or DCIS, if we're trying to rule out multicentric disease, or if someone has a positive lymph node but without a primary that's identified in the breast, we'll often get an MRI there to figure out if there's an occult cancer in the breast that we haven't picked up on mammogram or ultrasound. And then another reason for MRI is assessing response to neoadjuvant care. Systemic disease. So any patient who shows up with a known breast cancer who has lymph node involvement or any symptoms such as bone pain, unexplained weight loss, jaundice, they need to be systemically staged. And what that looks like is a PET CT, or what's acceptable as well is a CT chest, abdomen, pelvis with bone scan. So all are acceptable means of assessing for systemic disease. But yeah, there's definitely been questions before if a patient coming with a breast cancer and they have new unexplained bone pain, or if they have new onset headache, quote unquote, worst headache of their lives, not necessarily a subarachnoid there, but you do want to evaluate that. And typically the best way to evaluate for any head lesions or brain lesions, excuse me, is with a MRI of the head. So what do you need to know about staging, particularly when does it change management? So again, these are the breakdowns in staging. Don't worry about just memorizing all of these different stages for T or N or M. But what is helpful to know is when does it actually change your management? So with early stage disease, so typically stage 1, we're taking most of these patients to the operating room as long as they're surgical candidates. Stage 2, when you see potentially some lymph node involvement or larger tumors, it really depends. So I doubt you'll get many questions on someone who is like stage 2, just because it really goes either way depending upon the biology of their disease and what you're trying to do operatively. As you get more locally advanced, it's a pretty safe bet that these patients are going to be starting off with neoadjuvant chemotherapy first. And the whole purpose of this is if someone is, has a large tumor in the breast, or they've got multiple lymph nodes that are involved, we're trying to achieve two things. We're trying to control the disease that we know about, prevent it from disseminating distantly, and then also hopefully downstaging that disease. And it gives us information going forward in terms of any adjuvant therapies, because if you know that something has been effective in the neoadjuvant phase, then you can potentially rely on similar therapies in the adjuvant phase. But if cancers haven't budged at all, it doesn't make sense to keep repeating that later on, which is what the definition of insanity, right? And then with inflammatory breast cancer, we'll have a little discussion about this in particular because it's relatively high yield, but those patients are also getting neoadjuvant chemotherapy as well. And then for metastatic disease, if something pops up there and someone has what we call distant metastatic disease, so anything that is outside of the axilla, so bone, liver, lung, head, these patients traditionally are not surgical candidates. So it's a safe thing to say, defer them for medical management. All right, so moving on to the treating it phase of things. So starting off with DCIS. So DCIS, it's important to understand the definition histologically of DCIS because it makes more sense as to why we manage it this way. And management of DCIS is evolving, but I would say for your exams, these concepts still ring true. So DCIS is a non-invasive carcinoma. So it is not broken through the basement membrane. Therefore, it doesn't have access to lymphatics and does not metastasize to lymph nodes. There's about 1 in 5 breast cancers are diagnosed as DCIS, and so there's quite a lot of cases, about 60,000 annually, and usually it's going to present as non-palpable clusters of microcalcifications. So the important things here are, like I'd mentioned before, and this is kind of great. Get this, just kind of ground into your brain. So about 2 millimeter margins is the cutoff for DCIS. So if you're doing a lumpectomy or even a mastectomy for these patients, you want to make sure that on the final pathology you have at least 2 millimeter margins, because that's going to assure that chance of recurrence and more effective treatments, that patients are going to be successful there. So we see lower risk of recurrence when you have 2 millimeter margins or greater. These patients, if you're treating them with breast conservation, which is BCT, then you can do the lumpectomy, radiation afterwards, and there's no need for sentinel lymph node biopsy at that time. If these patients are getting a mastectomy, The safe answer on your exam, on your boards, is to do a sentinel lymph node biopsy at that time. And the reason for that is you've severed the lymphatics at the time of the mastectomy, and there's no way to do a sentinel lymph node biopsy later on. There are some exceptions to this. If any institutions you're at use mag trace, there's a way to do a delayed sentinel lymph node, but that will not show up on your exam. So the answer there is at the time of mastectomy for DCIS, you want to do a sentinel lymph node biopsy. And the reason for that is there's about a 25% chance of upgrade for invasive disease, especially when you have larger areas of DCIS. So you want to make sure you've assessed those lymph nodes at the time of the mastectomy, because that's really your last shot to do that. So radiation for these patients. So we recommend this for patients who have had lumpectomy operations, and it decreases the risk of recurrence by about 50%. And then if they're this DCIS is sensitive to hormones, so ERPR positive, these patients should be referred to medical oncology to talk about benefits of either tamoxifen or anastrozole, which will reduce future in-breast recurrence as well. So I put this histological slide up here just to, again, demonstrate DCIS in the ducts on the left-hand side versus invasive disease on the right-hand side. So you can tell there's a major difference. The DCIS is contained within the ducts, hasn't broken free, hasn't gotten into the lymphatics. The invasive disease is diffuse all throughout. So again, that's the reason why we manage it this way, and why we typically don't have to assess lymph nodes, especially with lumpectomies for DCIS. And then in terms of what it looks like, it may be hard to see just on this smaller monitor, but this is just an area of what we call pleomorphic or abnormal calcifications there. For invasive ductal and invasive lobular carcinoma, the early stage disease here, or if there's status post neoadjuvant chemotherapy, then or just neoadjuvant endocrine therapy as well. Breast conservation therapy or mastectomies are options. Important to know there's no survival benefit when you compare mastectomy versus breast conservation. So we don't do these or choose these operations based upon how we think their long-term survival is going to be. It has a little more to do, even though recurrence rates are still very good in either operation, but with mastectomy, the recurrence rate typically, and we're talking local recurrence in the breast or axilla, tends to be around 2% or less, versus with breast conservation, it's a little bit higher, about 5%. All right, this is an area where there's been a lot of evolution over the last a few decades, and definitely over even the last few years. So sentinel lymph node biopsy, typically I'd say a safe answer is for anybody with invasive disease that's clinically N0, a sentinel lymph node biopsy is recommended. And by clinically N0, we mean no palpable disease on your exam. Targeted axillary dissection, or TADS, this is relatively new in terms of exams, but we've been doing it. Even the group out of MD Anderson, I think, is maybe over a decade now. So sentinel lymph node, this is the combination of a sentinel lymph node biopsy and removal of clipped nodes, so nodes that we know have been biopsied and have proven cancer in it. We'll kind of get into the indications for that, but typically targeted axillary dissections can be done for patients with low burdens of axillary disease. And then axillary lymph node dissection, the situations to do that are if someone has inflammatory breast cancer, if someone has a high burden of axillary disease, which is typically defined as clinically palpable adenopathy, or if they have more than 3 lymph nodes. So more than 3 positive lymph nodes puts them into an N2 category, and that's the reason why it would be indicated for an axillary lymph node dissection. And this is an important point when you're doing the axillary lymph node dissection. They will often ask on exams, what level lymph nodes are you taking? So this would be level 1, level 2, and this is defined by Pec minor. So level 1, level 2, that's going to be the lymph nodes that are deep to Pec minor, as well as lateral to Pec minor. Level 3, which are going to be superior and medial to Pec minor, you do not need to take. And then lastly, they may ask about how many lymph nodes do you want in an axillary lymph node dissection. And the standard of care here is you want to get at least 10 lymph nodes, which allows for an adequate sample of the axilla. And that we start to see the false negative rates dropping below about 10% once we've removed 10 lymph nodes. So the magic number there is we want to get at least 10 lymph nodes. And then these patients, depending upon their hormone markers or their tumor receptors, will either, if they're ERPR positive and they're premenopausal, they're going to go on to tamoxifen. If they are ERPR positive and postmenopausal, they're going to go on to aromatase inhibitors like anastrozole. And the adjuvant chemotherapy depends on nodal status and the type of disease they have, but the most common combination that we use is what's called ACT, which is adriamycin, cyclophosphamide, and taxanes. So quickly, I'll go over this because I know we're getting towards the end of things. So this is the Z11 trial. If you're not familiar with it, it's worth at least kind of looking through the abstract. And the takeaway points here is that for patients who have had early stage clinical disease, so T1, T2, so that's less than 5 centimeters in size, again, non-palpable adenopathy, and they end up having 1 to 2 positive lymph nodes on a sentinel lymph node biopsy, these patients can move on to radiation without the need for an axillary lymph node dissection. That's the main conclusion here from the ICSOG Z11 trial. So worth sitting down with this for a few minutes, just reading through the abstract. You don't need to know it back and forth, but the takeaway points from the Z11 trial is that if you have 1 or 2 positive lymph nodes after sentinel lymph node biopsy, typically you can avoid an axillary lymph node dissection and move on to radiation. So how to handle the axilla here. What are the clear indications? These would be kind of the take-home points for an axillary lymph node dissection. So definitely indicated for inflammatory breast cancer. If you have clinically positive palpable lymphadenopathy after neoadjuvant systemic therapy, so let's say someone's got neoadjuvant chemo and they still have palpable lymphadenopathy, those patients have a larger burden of disease that needs an axillary dissection. And then N2 disease or N3 disease. So someone who's got 4 or more positive axillary lymph nodes, they're going to need to go onto an axillary dissection. And, if someone has residual disease after neoadjuvant chemotherapy on final pathology, oftentimes these patients will go on to get an axillary node dissection. Again, Z11 criteria there. And then for targeted axillary dissection, so these TADs, if someone has 1 or 2 positive lymph nodes that are clinically negative and non-palpable, then you can do a sentinel lymph node biopsy and then mark those lymph nodes for removal at the time of surgery. Also, if they had clinically positive lymph nodes, then undergone neoadjuvant therapy, and those lymph nodes have converted, so they were palpable before and not palpable after, then you can move on to a targeted axillary dissection. Again, that's taking out the clip node and the sentinel node at the same time. This is what an axillary dissection looks like. If you want the big points here, so you want to make sure that the intercostal brachial nerves, those are non-motor based nerves. So that may cause some paresthesias, but you can take those if you need to in order to get out positive nodes. But the nerves you need to know about for testing purposes and intraoperatively are the long thoracic, which is going to innervate the serratus anterior and cause wing scapula if it gets injured, and the thoracodorsal, which innervates the latissimus dorsi. If you bag that, then you're going to have a decreased adduction of the arm. So I know we're running low on time, and Dr. Leamy, just give me a shout if you need me to wrap things up. But these are for breast conservation. So the contraindications here, that's the take-home point. So you really want to make sure for breast conservation that there isn't multicentric disease. They cannot have inflammatory breast cancer, no previous radiation, and you cannot do it during the first trimester of pregnancy. And again, for invasive disease, the key there is no tumor on ink. And then I wouldn't worry about the relative contraindications there. Last few things here. So for inflammatory breast cancer, luckily this is rare, but it's a pretty nasty disease, considered T4. About 50% of these patients at the time of diagnosis have distant metastatic disease. The way to treat these patients, so the presentation here, usually it's a clinical diagnosis. So if someone has a proven underlying breast cancer and greater than a third of the surface area is red, swollen, and does not resolve with antibiotics, then you got to think that this is inflammatory breast cancer. The way you work these patients up and treat them, so they have a high rate of having axillary involvement and potentially distant metastatic disease. So you need to stage these patients. So stage them with a PET CT or with a CT chest abdomen bone, CT chest abdomen pelvis and a bone scan. They need to go on to neoadjuvant chemotherapy. After that, go on to a modified radical mastectomy, which is a simple mastectomy to remove the skin, nipple areolar complex, breast tissue, and then combined with an axillary dissection. They then go on to radiation. and then hormone therapy depending upon their receptor status. Paget's disease and phylloides. So really quickly, Paget's disease typically is involvement of the nipple areolar complex, oftentimes with an underlying DCIS or invasive cancer. The way that this is treated is you typically need to punch biopsy this area to prove the disease, and then do a central lumpectomy where you remove the nipple areolar complex, underlying ductal system, and a sentinel lymph node biopsy at that time. For phylloides tumors, 90% of them are benign, 10% are malignant. For the benign and borderline, you can just excise them with negative margins. For the malignant, you need to excise them with a 1 centimeter margin. So that'd be a take-home point there. But then also, you want to stage these patients, and you stage them differently than adenocarcinoma. So like most sarcomas, these phylloides tumors, they're going to metastasize to the lungs. So you want to make sure you've done a CT of the chest to rule out any disease involving the lungs. And I will, I can send this along later because I know we're getting low on time, but with pregnant patients, the really important things to know here is that breast conservation cannot be done in the first trimester, mainly because radiation is contraindicated. In the second and third trimester, you can do breast conservation, but the things you need to avoid, methylene blue and liposurin are teratogenic, and that comes up on test. So you cannot use any of the blue dyes for any pregnant patients. The other thing you cannot use in pregnant patients is Herceptin. We'll skip over this because it's not as high yield in terms of the endocrine or chemotherapy, but worth your time to at least kind of know the mechanism of actions of tamoxifen and anastrozole, as well as potential side effects, because it has snuck in there in terms of what the different side effects of these different medications are. And then lastly here, this is going over genetics. If you want to snag a few quick points here or there, the main thing to remember is that with the high-risk mutations, BRCA mutations, Cowden, Li-Fraumeni, the vast majority of these are autosomally dominant inherited. So if you're just taking a stab in the dark with a genetic mutation, it's very likely that it's autosomally dominantly inherited. And then so take-home points lastly here that I'll hit on again. These are the things that are going to likely pick up the most points for you. So with benign lesions that need to go to the operating room, that's atypical ductal hyperplasia and pleomorphic LCIS. Again, name it, stage it, treat it if you're getting lost in the weeds with things in terms of how to work up a cancer. So a complete oncologic operation, you need negative margins, and you need to stage the axilla if you have invasive disease. And you have to ask yourself for adequate lymph node harvest with an axillary node dissection, you need more than 10 or more lymph nodes. BIRADS, again, knowing that BIRADS 4 and BIRADS 5 needs tissue diagnosis and needs biopsy. For early stage disease, particularly stage 1, upfront surgery is the way to go. Stage 2, little trickier there, so I doubt you're going to get asked that. And then locally advanced disease, so stage 3, typically those patients are getting neoadjuvant therapy first and then moving on to surgery. DCIS, 2 millimeter margins. That's the answer that should come immediately to your minds whenever DCIS comes up. With invasive disease, there should be no tumor on ink is the answer there, or at least the buzzword there. For targeted axillary dissections, you want to use this for patients who have limited axillary burden. So 1 to 2 positive lymph nodes, or the cutoff would be if they have 4 or more, they need an axillary dissection. And again, with axillary dissections, you want to make sure that you're getting 10 or more lymph nodes. Breast conservation, the keywords there are the contraindications. So inflammatory breast cancer, first trimester of pregnancy, previous radiation, multicentric disease. Those are things that are going to prevent those patients from safely getting breast conservation. Inflammatory breast cancer, those are patients that you need to stage systemically first, then go on to neoadjuvant chemo, a modified radical mastectomy, which is a mastectomy with an axe dissection, followed by radiation. And then endocrine therapies and chemotherapies, the things, and apologies, I didn't have enough time to get through the details on that, but worth looking up in terms of tamoxifen and anastrozole, what their mechanisms of actions are and their potential side effects, similar to Herceptin. And then also doxorubicin, which is associated with congestive heart failure, cyclophosphamide, the buzzword there would be hemorrhagic cystitis, and docetaxel or taxanes, that's associated with neuropathy. So kind of knowing those mechanisms of actions and side effects. All right. I know that was like a blitz of all of that breast information. So hopefully your heads aren't swimming and you're not bored out of your minds, but hopefully you grab a few extra points on your exams. And yeah, I'll turn this over back to Dr. Alimi.
No, thanks so much, Dr. Greenwalt. That was fantastic. Dr. Greenwalt's last slide there is really high yield for the ABSITE, I would say. So definitely knowing the stuff that he's highlighted on that last slide, I think will get you a couple of gimme points along the way. Thanks so much for being with us, and we look forward to having you again next year. Little plug.
Of course.
Dr. Gage is going to be doing our HPB pancreas review. Thank you so much for being here. Dr. Gage is a former president of our society. And we're happy to have her. Thanks so much, Michelle.
Thank you. All right, hold on. Let me share my screen. All right, do you see the presentation?
Yep, looks great. Take it away.
Perfect. All right. Thank you everyone for having me. Thank you, Dr. Alimi, for coordinating this wonderful review for yet another year. My name is Michelle Gage. I'm a surgical oncologist and hepatobiliary surgeon at Walter Reed and Johns Hopkins. And today we'll be going through very rapid fire, very high yield review for the ABSITE on topics that they love to test. There's some very testable things in here. So I'll be going very quickly, but again, this is recorded, so hopefully you can look back. So we'll cover pancreas, liver, and spleen as it noted on the agenda. And I threw in a few slides at the end for GIST and adrenal. I know the wonderful endocrine speaker already went and covered some adrenal, but I think it's not lost to reinforce that since the ABSITE loves those adrenal questions. All right, so without further ado, we'll go ahead and get started. First with the pancreas. Two commonly mistaken anatomical anomalies are pancreas divisum and annular pancreas. So think for a moment, what is each one? Why does it occur? How do they present? Because they do present differently, and what is the treatment? So pancreas divisum is when the main duct and minor duct of the pancreas fail to merge during embryological development. So you'll see that at the top, A, B, C. These patients may be completely asymptomatic, so may not present at all. You can find this incidentally on an MRCP, for example. But if they do have symptoms, they typically present with pancreatitis, which sort of makes sense, right? They don't have the ideal anatomy for draining the pancreatic enzymes out of the pancreas, so they can get pancreatitis, especially of the head of the pancreas. Now, if it's a minor pancreatitis that just happens once, you can treat that per usual. But if it's a recurring pancreatitis, which can sometimes happen with these patients, then removal of the head of the pancreas is indicated with a Whipple procedure. Now, different from annular pancreas, which is also an embryological anomaly, where the dorsal bud and the ventral bud of the pancreas as they come together, they loop around or continue around the duodenum. So this is a cross-sectional view. This can also be found incidentally if it's a partial annular pancreas, for example, so not a 360 encasement. However, it can be tightened around the duodenum there. So these patients may present in young adulthood or late childhood as having early satiety, vomiting, abdominal pain, as you can imagine, as food gets stuck there. And with that treatment, you can consider a bypass such as a GJ, for example. All right, next, name this diagnosis. So this is a nice, beautiful, normal pancreas here on screen left. You can tell that the Hounsfield units are about the same compared to the liver and the spleen. In other words, the brightness of it is about the same. You can tell where the pancreas ends and begins relative to the retroperitoneal fat and the surrounding vessels. And then here, this is a nice example of a very severe acute pancreatitis episode. Lots of fat stranding, fluid. There's a little bit of maybe normalish pancreas there, but really just you can't tell where the pancreas ends and begins with that. So, pancreatitis. How do these patients present? What are the common causes? And what's your treatment strategy? So this is a classic picture of how patients with acute pancreatitis episodes may be sitting, for example, in the ER, sort of leaning forward. If you think about the anatomy of the pancreas, it's directly anterior to the celiac plexus, which is a dense nerve bundle. And when there's inflammation of the pancreatic tissue, that causes secondary inflammation of those nerves, those patients can present with severe back pain. And so they subconsciously lean forward, trying to get that inflammation off of those nerves. It helps slightly relieve their pain. Most common cause of pancreatitis in the United States is alcohol. Second most common is gallstones. Autoimmune is also common, one of the common types. You want to check an IgG4 with that. Sorry, technical difficulties for a second here. They could also have hypertriglyceridemia with triglycerides over 1,000, for example. It can be iatrogenic after an ERCP or surgery. Trauma, of course. Everybody loves the scorpion sting in the differential. And then just remember that certain drugs can cause it too, even common ones like hydrochlorothiazide, for example. And as for our treatment, we provide supportive care. Early enteric feeding is favored now, but if it's not feeding versus NJ feeding, choose the feeding option. We don't give antibiotics for routine pancreatitis, and these patients need a lot of fluid resuscitation, and you need to watch for signs of secondary complications. Now, the sequela of pancreatitis can be a pseudocyst. Why is it called a pseudocyst? Well, it's because it's just an inflammatory rind that the body has created to try to capture all of those digestive enzymes that have leaked outside of the pancreas. So it's not a true epithelialized cyst. It's just an inflammatory rind. For the treatment strategy, nice way to remember this is the rule of sixes. So you want to wait at least 6 weeks before interrogating these. And also, typically they're not symptomatic unless they're greater than 6 centimeters in size. So if they're asymptomatic, you can just leave them alone. However, if patients, if they're so large, greater than 6 centimeters, that they're pushing on the stomach, for example, patients can have severe early satiety, and those warrant some type of intervention. Most common intervention is an endoscopic intervention, cyst gastrostomy. However, if it cannot be achieved endoscopically, then it can be performed surgically. And here's an example of that. The reason we wait 6 weeks is that's about how long it takes for all of those digestive enzymes and the peripancreatic fluid to be walled off. Less than 4 weeks, it just kind of looks like a big mess, for example, here. And then greater than 4 to 6 weeks, it becomes this nice, well-encapsulated true pseudocyst. All right. Every once in a while, they still bring back these classic operations, especially as options on the test. So it's good to know what they are. So which one of, okay, so first of all, indications for this, chronic pancreatitis, reasons that a patient may have chronic persistent pancreatitis is number one, autoimmune pancreatitis. That can be confirmed with an IgG4. A patient could also have hereditary pancreatitis, and the most common genes associated with that are PRSS1, 2, SPINK1, and CFTR. So if a patient does have persistent pancreatitis, you can consider one of these operations. Now, in real life, we almost never do these anymore. We're doing a Whipple or a distal or a total. But again, these can come up on your exam, so good to know. So which one's a pusto? So the pusto is A. It's basically a lateral pancreatico-jejunostomy here. Which one's the beggar? That one is B here, where they've performed a central pancreatectomy and cored out a portion of the head of the pancreas and then brought up their jejunum. And then C, which one is the fry? And that one is sometimes described as a combination of the other two, where you've cored out the head of the pancreas and also done your lateral PJ. All right. Another devastating complication of pancreatitis could be infected necrotizing pancreatitis. Again, if it's not infected and routine pancreatitis, we do not give antibiotics. However, if there is a secondary bacterial infection of the pancreas, it's most commonly with gas-forming organisms. And that is first hinted on by a patient who's just not getting better despite the usual treatments of pancreatitis. And then you scan them and you see punctates of gas on that cross-sectional imaging. So this one is a little obvious, a little more dramatic, but that, that dark air within the pancreas. So first, for your treatment strategy, you need to confirm your diagnosis. So that's typically done with an FNA and a culture, so you know what organism that you're dealing with. Then, of course, treat with antibiotics, and you want to drain as minimally as possible, minimally invasively. So IR first, minimal invasive debridement if needed. So that step up approach typically done through the retroperitoneum to try to keep that collection RP and not in the main peritoneal space. Next devastating complication, high morbidity, mortality with this one, hemorrhagic pancreatitis. As we know, the pancreas secretes these digestive enzymes, amylase and lipase in active form, and they like to try to digest everything that they come in contact with, including blood vessels. So you could have extreme hemorrhage due to erosion into the major vessels. These patients present with hemorrhagic shock. If it's contained enough that they're stable, they can be considered for an angiogram or an IR intervention. However, if they are, of course, in shock, then it may require surgical exploration. But again, this devastating complication. All right, we're going quick. Moving on next, we'll cover the benign lesions of the pancreas, including serous cystadenomas, main duct IPMNs, side branch IPMNs, and mucinous cystic neoplasms. We've already covered the pseudocyst. Again, it's not a true cyst. It's secondary to pancreatitis. And then just remember that neuroendocrine tumors can present with cysts also. The neuroendocrine tumor is still the classic solid component. However, they can present next to or within a large cyst that can make them difficult to see. So keep that in your differential. All right, so first, high yield. The serous cystadenoma, the classic way that this is described is a honeycomb lesion. So you see the picture here in the corner. So it's a bunch of septated microcystic cysts together that looks like a honeycomb. These typically happen in older women, more commonly in the head of the pancreas, like in this picture. And again, these are benign. You do not need to remove them. You can leave them alone. So as with anything, if it's symptomatic, you can consider operation for symptomatic relief, but in terms of malignant potential, you just leave these alone. Mucinous cystic neoplasms, the buzzword here is the ovarian stroma. These don't have as much of a characteristic look. They're unicystic typically. There's a very strong female predominance. It's odd for males to get these. So if you remember that with the ovarian stroma that's seen when it is resected and undergoing pathologic evaluation, you can put those two together. These are more commonly found in the body and the tail, like shown here on this cartoon. These you do need to resect because they do have malignant potential. All right, and as for the IPMNs, remembering our high-risk stigmata. So any patient with obstructive jaundice, a mural nodule greater than 5 millimeters, greater than or equal to, and a main pancreatic duct greater than or equal to 1 centimeter, do not pass go. You're going to surgery. There's a very, very high risk that there is an underlying adenocarcinoma present with that IPMN. And so you're gonna want to take that patient for resection. Now, if they don't have those dramatic signs, but they have an enlarged cyst greater than 3 centimeters, or maybe a very small mural nodule, or a slight dilation of the main pancreatic duct, you want to evaluate those with an endoscopic ultrasound, and based on those findings and the size of the cyst, consider surveillance. There is an updated guidelines that came out in the last year and a half, I want to say. It's very similar. It's actually more lenient on the duration or the intervals of screening, but the high-risk stigmata and the worrisome features are the same. All right, so moving on to our malignant lesions of the pancreas, pancreatic neuroendocrine tumor and pancreatic ductal adenocarcinoma. So which one is which? The neuroendocrine tumors, no matter where they are in the body, whether it's the pancreas or the appendix, thyroid, adrenal, neuroendocrine tumors are very hypervascular. So that's here on the left. They're very bright on arterial phase imaging, as opposed to adenocarcinomas and pancreatic ductal adenocarcinomas, which are very dark on imaging. They are not vascular, very fibrous. All right, neuroendocrine tumors, they love to ask about. What is the most common functional neuroendocrine tumor? It's the insulinoma. What's the most common functional pancreatic neuroendocrine tumor in MEN syndrome? This is also the most common malignant functional pancreatic neuroendocrine tumor. That's the gastronoma. And then our other PNET friends are glucagonoma, VIPoma, and somatostatinoma. When you're thinking about the most common locations that these present, this cartoon can be helpful. So insulinomas, right here, the sideways eye, like to present in the body. Gastronomas, the forward G in the head of the pancreas. We'll talk about the gastronoma. And this is in the pancreas, I should say. Think about that gastronoma triangle. We'll talk about that in a second. Somatostatinomas also on the patient right side of the pancreas. And then VIPomas and backwards G glucagonomas like to occur in the tail. I love a nice clean chart with everything on it. So we'll go through these one by one, but save this for, the night before your ABSITE. Insulinomas, they present with Whipple's triad. I think I always joke that, Whipple's triad is kind of ridiculous. It's the same thing said 3 times, that the patient has low blood sugar, that they have symptoms of low blood sugar, and then you give them sugar and they get better. But it is what it is. That's Whipple's triad. That's how the patients present. And the test, very testable, is the relationship of proinsulin and C-peptide to insulin for these patients. So classic scenario is it's a person that works in the medical field, like a nurse or a med tech, and you're suspecting that they are injecting insulin into themselves. The way to know if someone has an insulinoma or whether they are having symptoms of exogenous insulin administration is for an insulinoma, the insulin and proinsulin and C-peptide will all be high. So proinsulin is the precursor to insulin, so that makes sense. If someone is injecting insulin into themselves, then their proinsulin will be low because their body won't be making insulin, and the C-peptide will always be low. These insulinomas, again, are usually benign, almost always. And because they're so symptomatic, they typically present when they're very, very small. You need to do everything you can to localize them before resection. Sometimes you've done a CT panc, an MRI panc, and a dotatate, and you just can't find it. So then you ask your GI colleagues to do an EUS FNA. If they can't find it on EUS, then you can ask your IR colleagues to do an Immunology procedure, which is selective arterial calcium stim test. So they cannulate the different arteries that supply the pancreas, so head versus tail, for example. Put some calcium into that artery and see if their insulin shoots sky high, and that can give you a hint on whether it's in the head or the tail. This is more oral boards, but if you can't localize it at all, even with all of those steps, you consent the patient for both operations and maybe even a total prior to going to the operating room, and then you mobilize the pancreas and you try to feel for it and do an intraoperative ultrasound to try to identify it. Typically you can find it prior to surgery, and as long as it's small and away from the main pancreatic duct, you can consider enucleation. Again, that's because these are usually benign, almost no chance that they've spread to the lymph nodes, so you don't need to do your formal oncologic resection of a Whipple or a distal panc with splenectomy. It can enucleate if it's technically feasible and safe. All right, gastronoma, again, occurs the gastronoma triangle shown here: distal stomach, duo, distal common bile duct. This question also is a very popular one because it tricks people up when you're studying this again the night before your ABSITE and you're thinking about all of the different pancreatic neuroendocrine tumors. They'll ask you, where's the most common place that a gastronoma occurs, and they'll give you a whole bunch of options for the pancreas, and you'll think, oh, it's a peanut, it must be in the pancreas, but actually the most common location is within the second portion of the duodenum. So it tricks people up. These patients will have an elevated fasting serum gastrin. And then for these, if you need diagnostic confirmation, you can do something called a secretin stim test. Again, this is the most commonly associated with MEN syndrome. So you want to screen for that first. And again, key point here found in the wall of the duodenum. This one, for this particular example, you'll have to proceed with a Whipple procedure to treat that. Now, if you have a pancreatic neuroendocrine tumor and they show you a picture of necrolytic migratory erythema, so this is a great picture, then it's going to be most likely a glucagonoma. These patients present with the 6 Ds: declining weight, dermatitis, depression, diarrhea, DVT, and diabetes. These are very malignant. Unfortunately, they're usually metastatic at presentation. And then last, the VIP-oma. These patients present with the WDHA syndrome. That stands for watery diarrhea, hypokalemia, and achlorhydria, which are symptoms, right, that they're caused by the watery diarrhea. These are also usually malignant and can be metastatic on presentation. So those are the common functional pancreatic neuroendocrine tumors, but the most common type of neuroendocrine tumor is a non-functional pancreatic neuroendocrine tumor. You can perform debulking operations if they're metastatic for these well-differentiated subtypes. If they're very small, less than 1 centimeter, then you can observe them, meaning just surveil them and see if it ever grows, and if it doesn't, then you can leave them alone. If they're less than 2 centimeters, then you can consider enucleation. They're very unlikely to have spread to the lymph nodes at that size. That's a T1. However, if they're greater than 2 centimeters, then you're going to be offering resection for these, and it's going to be your formal oncologic resection with lymphadenectomy, meaning a Whipple or a distal pancreatectomy, because the rate of nodal metastasis is higher for this. Now, again, these neuroendocrine tumors look very hypervascular on scan. Another hypervascular organ that lives close to the pancreas is the spleen. Sometimes you'll have a very hypervascular lesion right at the distal tippy-tip tail of the pancreas, nestled amongst right into that spleen, and it'll be a question of, well, is this a splenule or is this a pancreatic neuroendocrine tumor? And you'll ask your GI colleagues, can you EUSFNA this? And they'll say no, because it's right up against the spleen, so the risk of poking the spleen is too high. In these circumstances, you can order a dotatate scan. A neuroendocrine tumor would light up for that, while a splenule would not. If that's inconclusive, then you can order a tagged red blood cell scan. Those will be positive, or it'll light up for a splenule, but not for a neuroendocrine tumor. All right. Pancreatic adenocarcinoma, the most common primary cancer of the pancreas. Any mass in the pancreas is adenocarcinoma until proven otherwise, right? Very devastating diagnosis. So resection does not require a tissue diagnosis if the clinical suspicion is high enough. So if a patient has a main pancreatic duct dilated to a centimeter or more with an abrupt cutoff at a mass, that's very suspicious. If they have distal pancreatic atrophy, meaning their pancreatic parenchyma has shrunken down, that's also very suspicious. Painless jaundice with mass, very suspicious. And CA19-9 is the best tumor marker we have for adenocarcinoma. It can be falsely elevated in pancreatitis or in obstructive jaundice. So you want to check it when those are corrected, but very suspicious for adenocarcinoma. These are categorized as resectable, borderline resectable, or locally advanced based on the relationship to the anatomy. So there are a few different criteria out there. AHPBA has one, for example. The Alliance trial has one, but NCCN guidelines is your best bet. That's the one that is going to be asked on the test, and that's what's shown here. That's also most likely what's in all of your surgical textbooks. So there's a lot on this slide, but to keep it simple, for resectable, no contact, venous, less than 180. Borderline resectable, arterial, less than 180, venous, greater than 180, but reconstructible. Locally advanced, greater than 180 contact or in the arteries, or unreconstructible venous involvement. All right. It's still safe to say for resectable, go straight to surgery. You can consider neoadjuvant treatment for these patients, but it hasn't been universally standardized yet about how much to give for how long. Borderline resectable, you're always going to be giving neoadjuvant systemic treatment, and then locally advanced, of course, they're getting systemic treatment. And they can convert to resectable if they have a favorable response, but that's less common than the other alternative. All right, classic complications of the Whipple procedure. You can have delayed gastric emptying with a Whipple, of course, a pancreatic leak. You can feed through that as long as there's a drain in place that's removing that pancreatic effluence from the body, then it should be asymptomatic. And then, of course, the devastating complication of a GDA pseudoaneurysm, most commonly in the setting of a pancreatic leak. The safest answer is to go straight to IR, although that has become a little more conservative, but board answer, that's still the best bet. All right. I need to go faster. I'm sorry. All right. Anatomy, we could talk about liver anatomy for an hour. We won't do that right now, but just remember that there are 8 segments here. I won't belabor that too much. In terms of the different types of liver lesions, you can have bacterial abscesses that require antibiotics and percutaneous drainage, amoebic abscesses with E. histolytica that it's treated with flagyl, and then echinococcal cysts. The buzzword there is daughter cysts treated with albendazole and mebendazole. So here's a classic photo of those daughter cysts, echinococcal daughter cysts. Remember that? And again, treated with albendazole. Other cystic lesions of the liver, you can have simple cysts that are lined with epithelium. If they're asymptomatic, you leave them alone. If they're symptomatic, you can fenestrate them. But not every cyst is benign. You can have malignant cysts. For example, that's a cystadenocarcinoma down there on the right. Look, the septated, calcified, looks invasive. There's a high risk of malignancy or malignant conversion with a cystadenoma or cystadenocarcinoma is the malignant version. You've got to resect and treat those. All right, keep moving fast. So hemangioma is more common in women. The buzzword here is centripetal filling. You want to get a tragged red blood cell scan. You can leave these alone. Embolization is not going to work. You don't need to resect them if they're asymptomatic. The fun fact is that Kasabach-Merrick syndrome if it is a very, very large hemangioma. And here's a classic photo of that centripetal filling for those hemangiomas. For FNHs, these are more common in women. The buzzword here is a central non-enhancing scar. You can consider getting an EOVIS study if you're not sure if it's FNH or not. So FNHs are just a whole bunch of normal hepatocytes that are concentrated in an area. Again, these do not need to be resected if confirmed. So here's a classic picture. There's a little FNH there with the central scar, so it looks a little duller in the middle, basically. Hepatic adenomas, again, lucky us, more common in women. These are arterially hyper-enhancing, typically seen on liver MRI. These are sensitive to hormones and estrogens. So you want to stop the birth control. When you tell the patient to stop the hormonal birth control, please tell them to start a barrier birth control, or you're going to have a bigger problem on your hands. Meaning a adenoma in the setting of that you need to resect in the setting of pregnancy. Resect for evidence of any intratumoral hemorrhage if it's large, greater than 5 centimeters, or if it's present in a male. So there are certain types of subtypes that have more likely malignant risk. You'll see that down here, that beta subtype. When a man gets an adenoma, it's more likely to be that malignant subtype. It's just a little unusual for them to get it. So the threshold for resecting is lower for men. Again, you want to stop the hormonal birth control because these adenomas can shrink if you stop giving them that exogenous estrogen. All right, the most common cancer in the liver is metastatic cancer, and the most common location that it comes from is the colon, so colorectal cancers. Prognosis in terms of intention to cure for colorectal liver metastases depends on how many there are, what the CEA is, how large the biggest one is, and also if they previously had colon cancer without metastatic disease, but are now presenting with liver-only metastases. How long was that DFI or disease-free interval? The longer, the better in terms of prognosis. No role for any other GI epithelial malignancies at this time. So somebody with gastric cancer with metastases to the liver, pancreatic cancer with metastases to the liver, esophageal cancer with metastases to the liver, they do not have positive outcomes with metastacectomy. Now, if their metastasis is neuroendocrine tumor, well-differentiated subtype, and they have symptoms from their hepatic burden, then debulking can offer mortality benefit and symptomatic relief. All right, hepatocellular carcinomas, you can identify these on LIRADS. AFP reinforces that diagnosis. You don't need to biopsy if it's concordant on LIRADS. And of course, treatment is resection versus transplant. And a special subtype, very testable, the fibrolamellar subtype. These are typically seen in young males that don't have a history of cirrhosis. These are typically very large at diagnosis. They can be mistaken with FNH because they have a central scar. But they're going to ask you usually, what do you test for to verify that diagnosis? And the tumor marker is neurotensin. AFP will not be elevated for these fibrolamellar subtypes. Intrahepatic cholangiocarcinomas, these are from the biliary system, arising from the biliary system. CA19-9 is our best tumor marker for that also. It may be mistaken for metastases when it's intrahepatic, resect if possible. All right, surgical principles, you need at least 25 to 30% of healthy liver left. If somebody had neoadjuvant chemo, that number is going to be higher. If they had a hepatotoxic type of chemo, you want to monitor that FOS post-op. All right, I'm running a little behind, but the good news is there's not a lot of spleen questions on the exam. I think it's something like 1% of the ABSITE. So if there's an abscess, you can treat it. If there's a simple cyst, if it's symptomatic, you can treat it. You can also get echinococcal type cysts in the spleen, and you can perform a splenectomy for that. Moving on, more testable splenectomy indications for hematologic disorders. So hereditary spherocytosis is an indication, and ITP if refractory to steroids or in pregnant women who failed steroids. Overwhelming post-splenectomy sepsis risk is highest, of course, in the younger population in children, and the peak incidence is within 2 years. So what vaccines do you need to give prior to splenectomy and after splenectomy to help continue to protect against those encapsulated bacteria? So pneumococcus, meningococcus, and H. flu type B. All right, really quickly, last couple slides again. So GIST is very testable, so I just wanted to make sure to go through that. Remember that GIST is a type of sarcoma. Though if it's very, very small and a classic gastric GIST, you can observe. Again, it's a sarcoma, so you want to biopsy it from within, meaning from EUS. You please do not do a transabdominal biopsy on one of these. You will seed the tract and the abdomen and convert them to stage 4. 95% of gastric GIST express KIT or c-KIT, which is CD117. 5 to 10% have the PDGFRA mutation. And then another 10 to 15% don't have either of those, and they are considered the wild type. Other common markers, CD34, smooth muscle actin, and desmin. Confirm your diagnosis of a GIST. If you need to shrink your GIST because it's in a location that would require an aggressive surgical resection, so a classic example is right at the GE junction, that it necessitates a total gastrectomy. You can try to shrink it down away from that esophagus with some neoadjuvant therapy, so 600 milligrams of imatinib or Gleevec, and potentially be able to convert that to a wedge resection. The goal is negative margins. You do not have to do a lymphadenectomy. Again, this is a sarcoma subtype. It doesn't go to the nodes. It goes to the chest. So get your chest imaging pre-op and avoid tumor rupture again to avoid seeding. Adjuvant therapy is dictated by the rules of 5. So if it's greater than 5 centimeters or greater than 5 mitotic index, you're going to want to consider adjuvant Gleevec for those patients. If a patient comes in with a bleeding GIST, give them imatinib. It works very, very well for stopping bleeding in the acute setting. All right, I'm running late, but I'm just gonna click through these slides again. And adrenal's already been covered, so just make sure to review your adrenal topics before your ABSITE. And that's it.
Thanks so much, Dr. Gage, for being with us. And yeah, the adrenal high yield slide there, folks can review it as well in Dr. Noureldine's lecture. Thank you for giving us the highlights on pancreas HPB. We really appreciate it. We've got up next Dr. Jason Hawksworth, a transplant surgeon out in New York now, but formerly an OG of the DCACS ABSITE review. So we're glad he's always willing to come back and give you guys the highlights.
Hi everyone, can you guys hear me okay?
We can hear you. You're not in presenter mode yet though. And now I can see you. You have a beard now.
How's that?
It's nice. Yeah, it's good.
You can see, okay.
Yeah.
Are the residents like in an auditorium this year?
No, they're it's still virtual. They're here virtually. It's a webinar style.
Oh, I see.
So that's
Okay.
why you can't see them.
Because normally I pick on people and ask questions, but we'll skip that this year.
That is good to know. We will make sure that we can augment that for next time.
Yeah.
You guys are lucky.
Everyone's probably relieved. So thanks for inviting me back. It's a privilege to be able to give this talk to all of you. And I was in DC for a long time. I really miss it. But New York is great. I like Columbia. It's a great practice. So without further ado, I'm going to just give a couple of study tips. In my opinion, everybody's different, but I think the way to study for the ABSITE is to be very focused and just focus on the stuff that they want you to know. Don't try to read all of Savastin. It's almost impossible. You won't remember all of it. Stick to the high yield type study guides and do questions. So that's my advice. That always worked for me. I did well on the ABSITE for the most part. And then really stick to the high yield topics. So transplant and immunology are really not high yield topics. There's just going to be a couple questions. It's sort of the icing on the cake. If you have time to study for it, great, but focus on the other topics where there's more questions and really don't try to read the whole book. It's not going to work. So every year there's very consistent things that you need to know. And I know Dr. Gage already did some of the liver stuff, but I'll just kind of go through it quickly. If you can find sort of these high yield things to memorize, you can really limit how much you have to stuff into your brain and focus more on kind of getting used to the type of questions they're going to ask, the clinical questions, and just have a good understanding. A lot of the questions really are probing your understanding of the topics, not wanting you to necessarily memorize facts. But there are some things you have to memorize. So these are the top 10 things that I recommend memorizing for the ABSITE, and I'll go through them. They always ask about the anomalous hepatic artery anatomy. So the replaced right hepatic artery comes off the SMA, the replaced left comes off the left gastric. There's always a question that wants to know if you understand the portal triad. So just remember the portal vein is posterior, the bile duct is lateral, the artery is medial. There's usually a clinical question on cholangitis. The triad is jaundice, fever, right upper quadrant pain. The treatment is to resuscitate and give antibiotics first before you do any sort of biliary decompression, which is usually going to be an ERCP. Gallbladder cancer is very complicated. There's a few things that they want you to know. If the gallbladder cancer is confined to the mucosa, so a stage TA, 1A, then that's a cholecystectomy is adequate. Anything beyond that, they get a radical cholecystectomy, which is a wedge of segment 4B and 5 plus a portal lymphadenectomy. They ask about hemophilia commonly, although it's rare. The triad for that is GI bleeding, jaundice, right upper quadrant pain. Those patients need to go to IR for the most part and get an embolization. Gallbladder dyskinesia will come up. That's a low gallbladder ejection fraction, typically treated with an elective cholecystectomy. Hepatic adenoma, Dr. Gage covered this, but there's a bleeding risk, a very small cancer risk. If they're greater than 5 centimeters, in general, you're going to resect those. There's a lot of nuance to adenoma, but that's the things they want you to sort of memorize. They like asking about Cassavak-Merritt syndrome, which is super rare, but if a kid in particular has a very large hemangioma, they can get a consumptive coagulopathy and even heart failure rarely. Amoebic abscesses, very rare in the West, but common on test questions. The treatment is medical, flagyl. Echinococcal cysts, also very rare in the West, but common on test questions. It's a complicated topic, but usually aspiration, sometimes resection is the treatment. HCC is very complicated, but again, there's a few things they want you to memorize. It's associated with the tumor marker AFP. It's associated with hepatitis B and or hepatitis C and cirrhosis. Cirrhotic patients get surveillance for HCC because of the association. The Milan criteria is very simple. So one tumor greater than or equal to 5 centimeters or 3 tumors greater than or equal to 3 centimeters is an indication for transplant, which is the T2 criteria for HCC. So if you only have time to memorize 3 of these, memorize your hepatic artery anatomy, no cholangitis, no hepatic adenoma. So I'm going to do some questions, and normally this is interactive, but I'm just going to go through these. So which of the following is true about the hepatic arterial supply? So A is aberrant hepatic artery anatomy is present in almost half of patients. That's actually true. It's very common. The cystic artery usually is a branch off of the proper hepatic artery. It's actually usually off of the right hepatic artery. A replaced right hepatic artery arises off the GDA. We just said that it comes off the SMA. Hepatic artery provides 75% of the blood flow. That's not true. The portal vein provides 75% of the blood flow. The hepatic artery supplies the majority of the oxygenated blood, but not as much of the flow. So this one is true. Half the patients have aberrant arterial anatomy. During palpation of the hepatoduodenal ligament, a pulsation is felt behind and slightly to the right of the common bile duct. Which of the following does this pulsation likely represent? This question commonly comes up with a Whipple scenario. And this is the classic location of your replaced right hepatic artery, which comes off your superior mesenteric artery. So replaced right is the answer. Which of the following statements is true about the anatomy of the portal vein? It is formed by the junction of the inferior mesenteric vein and the splenic vein. That's not true. It's formed by the superior mesenteric vein and the splenic vein, which forms the portomesenteric confluence behind the neck of the pancreas. It's the most posterior structure in the pataduodenal ligament, so that one is true, right? We just did that in the top 10. It contains valves. That's not true. There's no valves in the portal vein. The left portal vein typically branches sooner. That's not true. The left portal vein is much longer than the right portal vein. The right portal vein branches immediately. The left portal vein travels all the way to the umbilical fissure before it branches. More liver anatomy, which of the following hepatic resections involves dissection in the plane of the falciform ligament? This is kind of a trick question. It's actually none of these. You would think that it would be a right triseg or left lateral segmentectomy, but the reason it's none is this is going back to your liver anatomy, it's very complicated and there's a lot of variance, but you should have a good general understanding that there's segments 2, 3, and 4 on the left, segments 5, 6, 7, and 8 on the right. The caudate lobe, segment 1, is kind of its own little liver with its own inflow and outflow. But if you're cutting, there's no surgery where you cut right along the falciform ligament or in the umbilical fissure. If you're doing a left lateral hepatectomy, you actually cut 1 centimeter medial to the falciform ligament so that you preserve these switchback vessels that come back to segment 4. If you're doing a right triseg, which would be a hepatectomy involving segments 4 through 8, so all of this and all of the right lobe, you're going to cut 1 centimeter lateral to the falciform ligament so that you preserve the inflow to your left lateral liver, which is your remnant. So that's why that's a trick question. Liver physiology, the reticuloendothelial function of the liver is primarily dependent on which of the following cells. So there's a lot of these sort of esoteric questions that show up on the ABSITE. If you have no idea what the question is asking and the answer somewhere in there, the answer is Kupffer cells, guess Kupffer cells, you're probably going to be right. They love asking about Kupffer cells. I don't know why, but that's the answer here. So they're reticuloendothelial cells, and they come up in test questions. So the liver makes almost all of your clotting factors, makes all of your protein for the most part. But there are a few that aren't made in the liver, like von Willebrand factor, which is made from your vascular endothelium. So sometimes it's easier to memorize which ones aren't made in the liver as opposed to memorizing all the things that your liver makes to answer these kind of test questions. So this is a clinical question that's not uncommon and kind of covers a lot of ground. So it's a liver mass, 25-year-old female on oral contraceptives. If the test question starts off like that, it's probably going to be a question about adenoma versus FNH, focal nodular hyperplasia in general. So this female develops right upper quadrant abdominal pain. A CT scan demonstrates a hypodense 6 centimeter mass in the right lobe of the liver. A technetium-99 scan reveals a defect in the area of the mass. Angiographic study reveals a hypervascular tumor. So typically this would be like a 3-phase liver CT or MRI. And on the arterial phase, which is the early phase, you would see a hypervascular tumor. You're not really going to do angiograms on these kind of patients anymore. And it says with a peripheral blood supply. So this is really describing a classic adenoma case, right? It's a 25-year-old female on oral contraceptives. It's hypervascular. And then this technetium-99 scan, which really targets Kupffer cells. Those are not present in adenomas. They're present in FNH. We don't really do technetium-99 scans anymore. We do MRI with EOVIS, but it's the same concept, really. So if adenoma doesn't have normal architecture, it's just hepatocytes with little arterioles. And so there's no reticuloendothelial system in an adenoma, whereas there is one in FNH. So the technetium-99 scan will be dark. If it's an MRI with EOVIS, it'll be dark, as opposed to an FNH, which will be bright. So anyways, this is a classic description of a hepatic adenoma. So the options are discontinuation of OCPs and observation with serial imaging, percutaneous liver biopsy, resection, arterial embolization, radiation therapy. So again, there's a lot of nuance to adenomas. The reality is that most hepatobiliary surgeons would probably try a trial of stopping the OCPs and then repeating the scan to see if it's smaller. But again, for test question purposes, if they're greater than 5 centimeters, this one's 6 centimeters, that's an indication for resection, so that the hard answer is a resection for an adenoma greater than 5 centimeters. And this is a classic adenoma question. So this next one is another liver mass. An asymptomatic 45-year-old female is found to have a 7-centimeter liver mass. A CT scan demonstrates an initial hypodense lesion with peripheral to central enhancement by contrast material. Which of the following is appropriate management? So what they're describing, and this can be described either with a CT scan or an MRI, is this classic sort of peripheral to central enhancement is describing a hemangioma. So whether it's a CT or MRI, if the clinical scenario has that wording, peripheral to central enhancement, it's almost always going to be a hemangioma question. Hemangiomas that are asymptomatic, we don't mess with those. We leave those alone. We just observe them, usually get a couple more scans and just reassure the patient and tell them to go away. This next one is kind of comparing hepatic adenoma versus FNH, focal nodular hyperplasia, a very common clinical scenario in reality for hepatobiliary surgeons like myself, but also common on test questions. So the adenomas are associated with OCPs. FNH isn't really associated with OCPs classically. There is a risk of hemorrhage with hepatic adenomas. There's a small risk of malignant potential, particularly with the beta-catenin positive adenomas. Sometimes we biopsy these to see if they stain for beta-catenin to assess their malignant potential. Pathology displays a central stellate scar is classic for FNH. So if you see that in a description, again, whether it's a CT or an MRI, central stellate scar is classically associated with FNH. And then contains Kupffer cells, the old Kupffer cell that keeps coming up. Those are FNH. That's why they're bright on the technetium-99 scan. That's why they're bright on an MRI EOVIS, because they have a reticuloendothelial system, i.e. Kupffer cells. Moving on to liver abscess, amoebic liver abscess or pyogenic liver abscess, or both. So these are comparing these. The reality is that we see a lot more pyogenic liver abscesses clinically, particularly in the West. We don't see a lot of amoebic liver abscesses, but these show up on test questions. So in both scenarios, patients will have fever, sort of malaise, abdominal pain, weight loss. They can be kind of indolent for both amoebic and pyogenic liver abscesses. Diagnosis requires a serologic testing. That's for amoebic. There's a serologic test for that. Transmission may be hematologic or via the biliary tree. These are the pyogenic abscesses that we see very commonly in a clinical practice, particularly in the West. Primary treatment is pharmacologic. That's amoebic. That's with Flagyl. And then preferred treatment is drainage and antibiotics. Those are the classic pyogenic liver abscesses. So these aren't hard typically if you just kind of memorize a couple of these differentiating facts. So Dr. Gage mentioned fibrolamellar cancer, which likes to show up in test questions. So comparing classic HCC versus fibrolamellar. So AFP is elevated in HCC, but not in fibrolamellar. This male versus female predilection, there's studies that show differing sort of demographics, but some will say there's more males, some will say there's more females. The reality is it's like young people get fibrolamellar HCC. Older people with cirrhosis get HCC, get kind of the classic HCC. Associated with hepatitis A is neither. Hepatitis A is like a foodborne illness that can cause hepatitis, but is not associated with cancer. Associated with cirrhosis is HCC. So HCC is the one that you see in your 60-year-old cirrhotic alcoholic or with hepatitis B or C. Liver metastases. This is a really easy question. Resection of hepatic metastases is clearly benefited. Which of the following cancers? Colon, obviously. Very rarely, if there's an isolated breast metastasis to the liver, in a very sort of rare scenario, we'll resect those. Stomach, almost never. Pancreas, almost never. Very, very rare indications for that. Lung, basically never. So moving on to cirrhosis. Cirrhosis is very sort of intimidating as a resident, when I was in your shoes. But there are some classic things that you need to at least understand, not memorize, understand to be able to answer questions on cirrhosis. So Child-Pugh classification, don't memorize the Child-Pugh classification. I deal with cirrhotics every day, all day. I don't know the specific numbers of the Child-Pugh classification, but I understand it. And it's important to understand it because it helps you understand the pathology of liver failure. So this question is saying, the The Child-Pugh classification of hepatic dysfunction includes all but which of the following. So bilirubin is in the Child-Pugh. So if you're jaundiced, you're not conjugating bilirubin, that's a sign of chronic liver disease. So that sort of makes sense. Again, you want to understand this, not memorize it. AST is not part of the Child-Pugh. That's just a marker of acute liver injury. Prothrombin time, so your liver makes all of your coagulation factors. So if your PT time or your INR is elevated, that's going to go along with cirrhosis. So again, that makes sense, understanding this. Serum albumin, your liver makes all of your proteins. So if your serum albumin is low, that goes along with chronic liver disease. So that's part of the Child-Pugh classification. And then ascites, and the one that's not on here is hepatic encephalopathy. So one way to look at chronic liver disease is there is synthetic dysfunction. Synthetic meaning the liver is supposed to normally make protein, coagulation factors, is supposed to conjugate bilirubin. So if it doesn't do those three things, then you have synthetic dysfunction. So that's bilirubin, PT or INR, and albumin. And then the other component, again, this is a very sort of oversimplification because there's crossover, but the other component is portal hypertension. So if you have chronic liver disease, your liver is stiff, the portal flow increases and becomes pressurized, and you get portal hypertension complications. And so the two aspects of portal hypertension that show up on the Child-Pugh are ascites, which is a consequence of portal hypertension, and then a hepatic encephalopathy, which is a consequence of typically shunting and dysfunction in metabolizing ammonia. So the answer is bilirubin. This should be hepatic encephalopathy, PT, INR, albumin, ascites. So again, understand the Child-Pugh, don't memorize it. This is another classic question related to portal hypertension. A 51-year-old male, known alcoholic cirrhotic, presents to the emergency room with hematemesis and a systolic blood pressure of 80. What is the initial management? So someone who shows up in the ER and is vomiting blood, this is a variceal bleed until proven otherwise. This is an emergency in capital letters. These patients can die very quickly. And when someone comes in really sick, you have to kind of put on your intern hat and don't forget to resuscitate, airway control, all those things. So the answer for this, it's kind of a trick question, but it's easy. So the answer is resuscitation and airway control. All these other things are secondary. So you have to resuscitate, get control of the airway because it's a lot of hematemesis. And then they might need a balloon tamponade. They're typically getting endoscopic variceal ligation. They might need a TIPS if it's recurrent. Emergency portal cable shunt, we don't really do those anymore for the most part. Another portal hypertension question, which of the following is considered a selective portal systemic shunt? So shunts are sort of a rare thing now because of TIPS. TIPS is actually a non-selective shunt. So what that means is selective versus non-selective. Selective is you're just decompressing part of the portal system. Non-selective is you're decompressing the whole thing. So TIPS is a classic non-selective portal decompression or portal shunt because you're sending the blood directly from the portal vein into typically the right hepatic vein. So it's a non-selective shunt. The only one of these that's a selective shunt is your classic Warren shunt or distal splenorenal shunt. In this shunt, you disconnect the splenic vein from the portomesenteric confluence and you sew it to the left renal vein. So you're just decompressing that esophagogastric variceal arcade, and you're allowing the rest of the portal flow to go into the liver still. So this is for typically non-cirrhotic portal hypertension, often in the setting of chronic portal vein thrombosis with variceal bleeds. So you're just decompressing that stomach esophageal arcade into the systemic circulation while preserving the rest of the portal flow to the liver. So this is your classic non-selective portal shunt. Don't memorize all these different shunts. It's really complicated, but do understand the difference between selective and the non-selective shunts. All right, so moving on to gallbladder. This is super easy. Which of the following usually produces gallbladder contraction? This is CCK, very easy question. So these post-cholecystectomy sort of scenarios are very common, and you have to be able to answer these questions. And these are very common clinical scenarios too, and you should have a very good understanding of how to manage these because it comes up all the time as a general surgery resident. The surgeon encounters difficulty during an elective laparoscopic cholecystectomy in a healthy 25-year-old female and opens the patient, rare these days. The 4 millimeter common hepatic duct has been transected 1 centimeter below the bifurcation. There is no hepatobiliary surgeon in the hospital. What is the appropriate therapy? So this is kind of like a question that if you know how to take multiple choice tests, you can answer this because one of these is not like the others. And so this is the answer. Basically, if you're not an hepatobiliary surgeon, if you don't have hepatobiliary training, you're not supposed to fix bile duct injuries because there's a high risk that the repair will fail and the patient will have chronic cholangitis for the rest of their lives. The lawyers know this, so don't do this. If you're a general surgeon out there and you cut a bile duct, you got to send it to your friendly neighborly hepatobiliary surgeon like me. All these other answers could be correct given, different scenarios. You can fix these duct to duct, you can do a roux in some scenarios, but again, the answer to this question on the test and in real life is you don't fix it yourself, you send it to a hepatobiliary surgeon. This next one, on the second postoperative day after an elective lap chole, a 40-year-old woman complains of nausea and abdominal pain. Examination shows a fever of 100 degrees Fahrenheit, heart rate in the 100s, mild abdominal distension, and moderate right upper quadrant tenderness. What should be done next? So, there's different ways to kind of manage this, but basically, what you're trying to do is figure out if they have a bile leak or not. And to do that, you typically need cross-sectional imaging for the most part. And then you'll need some sort of functional imaging. So a lot of us will actually get MRCPs now because that gives you both cross-sectional imaging and it gives you some sort of assessment of the biliary tree, although it's not always perfect. But the point of this question is that you want to look for a biloma in a patient that comes in like this a couple days, after a chole, rule out biloma, and then you want to look for some sort of biliary injury. These are the two things that you want to look at. So this isn't a perfect question, but that's sort of the point of it. This is a better question. So post-cholecystectomy, a stable patient has this endoscopic cholangiogram following a lap chole 4 days previously. So post-op day 4, this is the scope coming down. There's a wire that goes across the ampulla. They're injecting contrast. You can see the pancreatic duct here, and then the bile duct comes up. There's a clipoma here, and there's no contrast past it. So presumably the bile duct is injured here. It could be clipped shut. It could be leaking. You don't know. Again, we need cross-sectional imaging to see if there's a fluid collection there, biloma. You can't tell that from this. So the question is asking what should be done next. This is 4 days post-op, so there's a little bit of controversy around this, but a lot of hepatobiliary surgeons, if it's more than 3 days after the injury, we don't like to rush in there and try to fix it because everything's really inflamed. There's some nuance to that, but a lot of the time we'll temporize these. So if you can't temporize it with ERCP, and then you're typically going to have to come in through the liver percutaneously. So the answer to this is a PTC. PTC will allow you to get into the liver, study the bile ducts, antegrade, see if it's just clip closed or if there's an associated biloma, if there's also a leak and a obstruction, see if they need a drain, and you can temporize them, optimize them, treat sepsis, optimize nutrition, and then do a delayed repair 6 weeks later, typically, if you can. So there again, as an hepatobiliary surgeon, there's a lot of nuance to this kind of stuff, but in general, they're asking, how do you decompress this? You can't do it with an ERCP, so you're going to do it with a PTC. So that's the answer to this question. Cholecystitis, with regard to acalculous cholecystitis, which is the following is true. It commonly affects elderly patients in an outpatient setting. Not true. These are usually sick inpatients. The primary pathophysiologic feature involves gallbladder ischemia. That's actually the answer here. So we see this in trauma patients. We see this in older patients who had cabbage, for example, with a long pump run. And it's related to ischemia. The gallbladder gets ischemic, and that's why it acts like a cholecystitis. HIDA scan will be positive. Ultrasound imaging is usually not normal. Cholecystectomy is not typically the answer because these patients are really sick. So we put in typically a percutaneous cholecystostomy too. This comes up a lot clinically. All right, so cholangitis question. Which of the following is the initial treatment for a patient with acute cholangitis? So this is, again, if someone's sick, cholangitis patients can get really sick, they can die. Um, Again, put on your intern hat and you have to resuscitate these patients before you do any sort of biliary drainage, which is the next step. So the answer to this is intravenous antibiotics. Again, if you're a good test taker, you can look at these and see which one of these isn't like the other. These four answers are all different ways to decompress the biliary tree given different scenarios. But again, they're asking you, they want you to just not forget to resuscitate the patient, do antibiotics, all of that before you do any of these things. With regard to the management of a patient with gallstone ileus, which of the following statements is true? So I've seen gallstone ileus maybe twice in my whole career, and then I've probably seen it like 50 times on test questions. But I'll just go through these different answers. So A, initial tube decompression and non-operative management allows spontaneous stone passage in affected patients. That's not true. This is, although it's an ileus, it's a misnomer. It's actually a mechanical obstruction. Operative treatment attempts to displace the stone into the colon without enterotomy. Typically, you can't pass the stone through the ileocecal valve. So this is false. Obstructive treatment is by enterotomy proximal to the site of the obstruction. This is actually the answer. So you don't want to make the enterotomy over the site of the obstruction because that part of the small intestine is typically very inflamed and it won't heal well when you try to fix it. So you milk it proximal and then you make an enterotomy, pull the stone out. Cholecystectomy and fistula repair at the time of stone removal are contraindicated. So typically we don't do that at the time of the operation. These are usually sort of elderly people, and this is a big project. So you either never do that or you delay it. Standard treatment is initial laparotomy for stone removal and mandatory reoperation. No, so this is not true. Um, the other thing that you can't forget when you do one of these cases, again, they're rare, is you have to run the whole small bowel and make sure there's not a second stone, so you don't do this enterotomy, pull out a stone, and then they just get reobstruct like the next day. Gallbladder cancer, adenocarcinoma of the gallbladder extending into the subserosa is discovered incidentally following a cholecystectomy. Recommendations include which of the following. So again, if the adenocarcinoma is just in the mucosa, a T1A, they just get a cholecystectomy in general. Anything beyond that, they get a radical cholecystectomy. And so radical cholecystectomy is resection of segment 4A, I'm sorry, 4B and 5 plus a portal lymphadenectomy. So that's the answer to this question. Gallbladder cancer is super complicated. Cholangiocarcinoma is super complicated. There's just a few things that they want you to know about these two types of diseases. Trying to know everything about these types of cancer is just not good test taking preparation. Cholangiocarcinoma, which of the following is a contraindication for resection of a cholangiocarcinoma? Again, cholangio is very complicated. It's one of the hardest problems in hepatobiliary surgery. We have like a whole lecture series on this, but so what they're asking here, this is a very easy question, peritoneal metastases. But so what they're trying to get at is tumor location in the distal common bile duct. That's resectable, typically with a Whipple. Tumor location at the bifurcation of the bile duct, which is a classic Klatskin's tumor, will typically get a resection, either right or left hepatectomy, depending on which side of the bile duct the cancer is infiltrating more. Invasion of the right portal vein and right hepatic artery. So that would typically necessitate a right hepatectomy. Where you have, let's say, invasion of the right portal vein and the left hepatic artery, that's considered unresectable in most cases. And that might end up being a transplant case if they meet the Mayo protocol criteria. So again, this is very complicated. One of the things that they'll ask you or they'll want you to know in a question about cholangio is understanding the principles of a liver resection. So when you're doing a liver resection, your liver remnant not only has to be adequate size, like Dr. Gage talked about, but it has to have arterial inflow, portal vein inflow, it has to have biliary drainage, and it has to have hepatic vein outflow. So if they give you a cholangio scenario where, again, let's say the right portal vein is involved and also the left hepatic artery is involved, there's no resection where you can maintain inflow to your remnant with both arterial and portal flow, biliary drainage and outflow. So that's an unresectable case. So it may be a cholangio question, but they're really trying to get you to understand the principles of a liver resection, which I just went through. Okay, so moving on to transplant and immunology. Again, there's like so much information you can learn about transplant and certainly immunology. And none of us, unless you're an immunologist, want to do that. But there are some things that show up commonly on the test, and just memorize the things that they test commonly. Otherwise, you'll go crazy. So these are the top 10 things that might show up in a test question. Again, there's just going to be a few questions on transplant immunology. So if you're running out of time studying for the ABSITE, skip this. If you have time, just try to memorize the things that come up commonly. So I'm going to go through these. Number one, IgM is made before IgG in response to infection. Next one is variable region of antibodies responsible for antigen recognition. I know this is like making everyone groan. This is like basic science immunology. MHC1 in all nucleated cells, single chain activates CD8. So just if you memorize MHC1 and CD8 T cells, and then MHC2 is on antigen presenting cells, which is your B cells, dendritic cells, monocytes. They're double chain and they activate CD4 T cells. Graft versus host disease is mediated by T cells. They love asking about that. I don't know why. 4 flavors of rejection. So hyperacute rejection is caused by preformed antibodies. That's why we do a cross-match to prevent that. We don't really see that anymore because cross-match is very good. Acute cellular rejection is lymphocyte T cell response to foreign MHC antigens. So you don't see that right away. You might see it a couple weeks later because it's a type 2 immune response. So it doesn't happen right away. It happens later. Acute humoral rejection is antibody response. We see that a lot in post-kidney transplant patients. That comes up. Chronic rejection, nobody understands why this happens, but it results in progressive graft fibrosis. Most transplants don't last forever. They all have a finite lifespan because we don't understand chronic rejection. Immunosuppression is largely cellular, so the discovering of the T cell and then the T cell receptor, and then cyclosporin, and then Prograf. These are all T cell sort of targeted therapies. This is what allowed us to be able to do transplants, is understanding of the cellular mechanisms that cause rejection. But because we suppress mostly cellular mechanisms, there's a higher risk actually of viral infections and fungal infections versus bacterial infections. Bacterial infections post-transplant are often related to surgical complications like a bile leak or urine leak or whatever. CMV is the number 1 virus post-transplant. We prophylax for that with valcytes, valganciclovir. If someone comes in with CMV infection, we treat with IV ganciclovir. Cyclosporin and FK506 or tacrolimus block IL-2. IL-2 allows T cells to proliferate once they're activated. So you're blocking that receptor that allows them to activate. Again, this stuff is super complicated. Just memorize a few facts about these different drugs and these different sort of mechanisms, and you could probably get through a question, at least be able to narrow down a multiple choice question to 2 answers and have a 50% chance of getting it right. The main side effect, ironically, of these medications is nephrotoxicity. So you're actually giving a drug to a kidney transplant patient, most commonly that's nephrotoxic. Biliary complication after OLT is orthotopic liver transplant. You need to assess the hepatic arteries. That's an important anatomy question because the biliary tree is almost exclusively supplied by the hepatic artery. So if your hepatic artery clots, sometimes that can present as a biliary complication of your biliary sepsis, stricture, leak. So whenever there's a biliary complication, the first thing we do is we look for the hepatic artery with ultrasound or CT scan to make sure the artery is okay. The most common cause of oliguria post-renal transplant is ATM. This comes up a lot in questions, and I have a question to understand. So the top 3 things, graft versus host disease is mediated by T cells. CMV is number 1 virus post-transplant, treat with ganciclovir. So again, this stuff is complicated, but if you remember the association between CMV and ganciclovir, you could get that test question right, probably. And then HSV or herpes is treated with acyclovir. So memorize HSV, that association with acyclovir, you might be able to get that question right if you don't otherwise know what they're talking about. And then these post-renal transplant questions are testing to make sure you understand that TPN is, or I'm sorry, ATN is very common after kidney transplant. So rejection question, which of the following statements regarding kidney transplant is true? Cross-matching is performed before kidney transplant to prevent graft loss from chronic. Again, cross-match is for the hyperacute to look for preformed antibodies. So this is false. A negative cross-match is a contraindication to cadaveric renal transplant. It's the opposite. If the cross-match is positive, if the blood reacts to preformed antibodies, that's a it's not a contraindication, but in general, for test taking purposes, it's a contraindication. So we want a negative cross-match, not a positive cross-match. This is false. Hyperacute rejection is due to NK cells. Not true. We just did that. Routine screening of potential recipients using the panel reactive antibody test, or PRA, can predict the presence of donor-specific antibodies. So PRA has to do with the cross-match. When you actually rotate on transplant, you hear us talk about PRA a lot. So again, like if you have no idea what PRA is, if you have, know some of this and have good test taking skills, you could narrow down and, maybe guess this one right. Acute liver failure is rare unless you're in a liver transplant program, but it's very dramatic. These patients are very sick, and there's just a few things that you should understand about it, and you could maybe get a question like this right. A 30-year-old female attempts to commit suicide by ingesting an entire bottle of Tylenol, which is the most common scenario. She presents to the ER obtunded, AST of 10,000, T-Billy is normal, 0.5, INR is very high, 6, and she's anuric. Often liver failure is associated with renal failure, so that you'll see these commonly present together clinically. What statements regarding acute liver failure is false? N-acetylcysteine is an antioxidant that can be used to treat acetaminophen overdose. That's true. We use N-acetylcysteine for almost all causes of acute liver injury and liver failure. There's data to support that. Coagulopathy and encephalopathy are the principal determinants for liver transplant listing. That's true. So these patients don't get listed with the classic MELD score. The MELD score is a composite of the creatinine, the INR, and the bilirubin. There's some other components now. There's a MELD 3.0 now that has some other things, but those are the main three components. So when someone comes in with acute liver failure, not chronic liver disease, they actually get listed status 1A, and status 1A criteria is based off of coagulopathy, INR greater than 2, and if they're encephalopathic and they're in the ICU and stuff like that. Renal failure is common in the setting of acute liver failure. I just said that. Mortality is typically related to hemorrhagic complications. So interestingly, acute liver failure doesn't cause you to bleed to death. It actually causes cerebral edema and you herniate and die. So that's how these patients die, which you wouldn't know unless you'd actually seen this before. Kidney anatomy. So I used to always get these questions wrong because I didn't really see any kidneys in general surgery residency until I did transplant. But you should know this. Which of the following is false regarding renal anatomy? Renal arteries are end arteries. That's true. The left renal vein usually crosses anterior to the aorta. That's true. The right renal artery crosses posterior to the vena cava. True. The right adrenal and gonadal veins typically empty into the vena cava directly. That's true. On the left, they empty into the left renal vein. The renal pelvis is anterior to the renal vessels. It's posterior. So when you scrub in on the living donor nephrectomies and pay attention to the orientation, the vessels are anterior, the renal pelvis is posterior. And then multiple renal arteries are seen in approximately 20 to 30% of patients. So that it's common that there's vascular anomalies in kidney anatomy, just like there is with liver anatomy. Not as common as with liver anatomy, but pretty common. So understand your kidney anatomy, take 2 seconds to look at a picture of it, and you can get a question like that right. Okay, so here's your classic ATN question. 2 hours after a transplant with a kidney from a 60-year-old donor, a 30-year-old woman with lupus, negative cross-match. Again, remember, negative is what we want. 10-hour cold ischemia time, has poor urine output with only 20 to 30 cc's an hour. What are you going to do with this? Immediate renal flow scan. We don't do renal flow scans typically. Immediate sonographic studies. That's the answer. Immediate re-exploration, immediate administration of high-dose steroids to treat rejection. So again, ATN is the most common thing that you'll see after kidney transplant. This is a 60-year-old kidney, older kidney, with 10 hours of full time, which is a decent amount. So that may not work well right away. It may take a couple days or even a couple weeks to kind of recover from the transplant process and the ischemia reperfusion injury. So this is just ATN. So you want to get an ultrasound just to make sure that your vessels are okay, the vein, the artery. The most common vascular complication, aside from bleeding after kidney transplant, is renal vein thrombosis. Actually, it's not arterial thrombosis. So we really, if the kidney is not acting as expected, we really look at that vein hard. Immediate re-exploration, you would only do that, let's say, after a living donor kidney transplant, where the risk of DGF, delayed graft function, or ATN is only around 1%. So if a living donor kidney isn't making urine, there's probably something seriously wrong with it that needs a reoperation. So that's the one scenario where we would reoperate right away if a living donor kidney is not working. Immediate administration of high-dose steroids to treat rejection. So high-dose steroids treats cellular rejection. We just talked earlier, you don't see that right after transplant. You see it a week or a couple weeks later. Okay, so immune response. I'm going to skip this one. I'll send these slides out. Give me this immunology stuff. Okay, so this is a clinical question that's very common, can be common on the test, very common clinically, lymphocytes. So treatment of the lymphocyte after kidney transplant, these are very common. We see these all the time. Include all except which of the following: percutaneous drainage to exclude urinoma regardless of symptoms. So fluid collections after kidney transplant are very common. Up to 80% of patients, if you study them, will have some sort of fluid collection, particularly if you leave the kidney in the retroperitoneum, which we usually do. But it's rare to have a urinoma. So we usually leave these fluid collections alone, presume that they're lymphocytes, only treat lymphocytes if they cause symptoms or graft dysfunction. If they do, so we can do percutaneous drainage with sclerosis, prolonged external percutaneous drainage. That's a way to manage it. Again, I just said this, observation if asymptomatic, and sometimes we do laparoscopic internal fenestration. So if there's a fluid collection post-kidney transplant, you don't have to automatically drain that to exclude urinoma. Usually you just leave those alone unless they're causing a problem. Urinomas would be suspected if the creatinine is higher than you would expect. And patients will get an ileus typically from a urinoma. They might get fevers and stuff like that. So that's when you would drain one of these. This is an immunology question. I'm going to skip this. Okay, so liver transplant scenario. Liver transplant contraindications include which of the following? So the first one, 60-year-old patient with cirrhosis with a 3-centimeter HCC. So remember the Milan criteria, that's within Milan criteria. This is a T2 HCC. That's a hard indication for a liver transplant. 30-year-old patient with liver failure and hepatopulmonary syndrome. That's an indication for liver transplant. 30-year-old patient with liver failure and portal vein thrombosis. That used to be a contraindication. Now we do a portal vein thrombectomy or an endovenectomy or a bypass. We can transplant these patients. 60-year-old patient with cirrhosis and a 3-centimeter HCC with portal vein tumor thrombus. So this is not a T2 HCC. This is HCC with vascular invasion. That's generally, again, there's nuance to a lot of this, but that's generally a contraindication to liver transplant. 45-year-old patient with alcohol cirrhosis and E2H abstinence for 6 months, that's an indication. This is the answer. So even if you don't know like what a hepatopulmonary syndrome is, if you know Milan criteria, you can answer this question. I'm going to skip this one, immunology stuff. Okay, so CMV. So remember, if you memorize CMV is associated with ganciclovir, you can probably get through a question like this where you may not know what all this is, what they're talking about. Which of the following statements is false regarding CMV infection after a solid organ transplant? Infection with CMV following transplant is best treated with acyclovir. Again, herpes is treated with acyclovir. CMV is treated with ganciclovir. So this is false. Incidence of symptomatic CMV infection is declining owing to utilization of screening tests. That's true. Patients at highest risk for developing CMV infection are those who test seropositive for CMV IgG. That's false. So if you're CMV naive, and let's say you get a CMV positive organ, then your risk of developing CMV is higher. That sort of makes common sense. CMV infection is more likely to cause chronic allograft nephropathy than infection with BK. Not true. BK can cause chronic allograft nephropathy. But even if you have no idea what BK virus is, again, if you know, some other facts about CMV, you can rule this one out. CMV can cause pneumonitis, gastroenteritis, CNS disease, retinitis, hepatitis. That's true. So this one's false because acyclovir is for herpes. TNF alpha, we use this to treat Crohn's disease. So that might come up on the on a test. I'm gonna skip this. Okay, so infection. So this is a 56-year-old female is admitted to the hospital with high fever and elevated creatinine, disseminated varicella skin lesions, bilateral pulmonary infiltrates. So this is a bad viral infection post-transplant. This is very dangerous. This patient has a high mortality, actually. And so that's basically the answer. This is very dangerous, a disseminated viral infection in transplant patients. So it's kind of testing that you understand that transplant patients are immunosuppressed, and specifically their cellular mechanisms are immunosuppressed, so they're susceptible to viral infections. I'm gonna move on. I'm going to do this one. This is kind of testing drug side effects. Again, these medications have a million side effects, but there's a couple that are very common. And if you can memorize like one side effect that's most strongly associated with each of these medications, you might be able to get a question right that you wouldn't otherwise get right. So mycophenolate is toxic to the gastrointestinal system. That's very true. That's the most common side effect. Mycophenolate or MMF or Cellcept, different names, has a lot of GI side effects. So that's very common. Tacrolimus has been associated with an increased incidence of post-transplant diabetes. That's actually correct. The most common side effect is nephrotoxicity, which we talked about. This next one, the calcineurin inhibitors, cyclosporin and tacrolimus. Again, cyclosporin and tacrolimus are both calcineurin inhibitors and have very similar side effect profiles. Tacrolimus is sort of the newer version of it, works a little better, but they do have nephrotoxicity and neurotoxicity. So the last one, cyclosporin, is associated with poor wound healing. So this one's false. It's actually sirolimus or rapamycin. The classic side effect association with that drug, that immunosuppression, is poor wound healing. All right. So again, it seems like bewilderingly complicated trying to memorize all these different side effects, but if you just memorize like a couple of the most common ones with each of these drugs, you can get through a test question. PTLD is a type of lymphoma that we see post transplant, pretty rarely, more common in kids, and it's associated with EBV. So if you don't know anything else about PTLD, if you just memorize that PTLD is associated with EBV, you could work through a question like this. So PTLD is more common in children. That's true. Treatment includes reduction of immunosuppression. That's true because it's an immunosuppression complication. The disease is related to the recipient's immunity to EBV. That's true. It's not related to CMV. It's not totally true, but for test question purposes, this is the answer. All right, so back to the top 10. For liver and hepatobiliary, here again, I'll send these slides out, and then top 10 for transplant immunology. And I can answer any questions.
I'm checking the chat. I don't see any presently. But if folks have any last minute questions for Dr. Hawksworth on transplant immunology, we're happy to take them now.
I see one that talks about hemangiomas, or is that the last?
Yeah, I think that Michelle responded to it.
Yeah, adenomas are the ones that we go after. Those are the dangerous ones. Hemangiomas are usually pretty harmless.
Well, thank you again, as always, for joining us. Thanks, residents, for hanging on, for those who are still on. We'll be back again live at 9:30 tomorrow morning. In terms of housekeeping, you should have gotten a link for the webinar. We will try to update the format, hopefully, as I know that some of the presenters tomorrow really have a lot of Q&A, and you get the best benefit out of this if you're engaged, I think. And so feel free to tell all your friends that as long as they register, they'll also get the video for the session today, even if they weren't able to be present, so they can still get access to that as long as they go ahead and register. Have a good rest of your day. Try to stay dry. It's at least wet here in DC. Thanks, y'all.